Good morning. It is August 15, 2019, and I'm Dr. Deuk. We are broadcasting spine surgery live from the operating rooms of the Surgery Center of Viera, affiliated with Deuk Spine Institute, and we are going to be performing a Deuk laser disc repair this morning on the lumbar spine in a patient who has herniated discs at L23, L45, L5S1. Our patient is suffering with back and leg pain. Now, this patient happens to also have pain coming from the piriformis, piriformis muscle on the opposite side, as well as the trochanteric bursa in the hip, as well as the ischial tuberosity, where the attachment of the hamstrings muscle is. So this patient has disc pain and disc problems from herniated discs. They also have muscle and other bursa problems, which we're going to address all of them during the surgery. Okay, good morning.
Not the morning.
It's a great morning. Great morning. So great morning to you. All right, I'm talking to my patient. She's awake. All patients that have the lumbar are awake for the beginning, and then I'm going to put her to sleep once I'm safely where we need to be in the disc, and we have access to the herniation, but I need her awake and helping me in the beginning. Okay, we're going to use an x-ray machine to navigate to the point where I need to go into the disc through the foramen. The foramen is a natural hole or opening on the side of the spine, and that's one of the advantages of the Deuk laser disc repair, is that we go through a natural hole. We don't make holes in the spine using a drill like other surgeons do. And you can only get the Deuk laser disc repair here at Deuk Spine Institute in Florida. All right, dear, I'm going to give you some numbing medicine, okay? You know the story. You know what to do. We did your other side before, and you know that if you feel any discomfort, just say ouch, and I'll give you some more numbing medicine, okay? Deal? And also, just don't move around during the surgery. Just lay still. So if you need to get comfortable, you want to move around a little bit right now, this is the time to do it before we get started. Are you comfortable?
Yes.
All right. I'm going to go ahead and get started. You'll feel a little stick and burn, okay? Now we're going to need to do 2 incisions because she has an L23 disc, which is, yeah, that's normal. That's just me putting the numbing medicine in. I apologize. It's never comfortable. For some reason, I don't know why, but putting the numbing medicine in actually hurts. I guess it's the acidity, isn't it? The acidity of the injection? Or is it too acidic or too basic?
It's too acidic.
That's what I thought. That's why you put sodium bicarbonate to reduce the acidity?
Well, you're trying to speed up the onset.
Yeah.
You have a very neutral medium. So
A very what?
neutral medium.
Oh. Here you go.
So you don't want the trauma state to be on a timeline, far.
All right. Well, Dr. Santiago, our awesome anesthesiologist, is explaining why the local injection is painful. We're going to get started. Now, for those of you who have never watched one of these surgeries live before, I like to talk, I like to educate, I like to answer questions, and I'll be talking to the patient, I'll be talking to the team, I'll be talking to the audience watching, the viewers like you. And the reason we do the live stream is so you can ask questions during the surgery, but also so that you can feel like you're here with us in the operating room. Zach, why don't you take a quick tour around the OR? Let's go ahead and cover up the name on the fluoro monitor and the name on the board. And there's no name on the laser monitor. So just give us a second, Zach, and then you can show the audience what the operating room looks like, okay? And if you need us to turn the lights on for a minute, we can do that as well, just so the audience can see the OR. All right, I'm going in and putting some numbing medicine in. Are you comfortable so far? So far. All right, so I want to get an AP. All right, good. So I'm too high, too far north. I need to head south a little bit. I'm sorry. Where shot? Let's see where that is. Okay. Shot. Let's go to a lateral. Zach, whenever you're ready, we can take a tour around the operating room. Wait, you got to cover that name. And on the MRI scanner as well, MRI images. Zach, can you hear me?
Yes, sir. Whenever you're ready.
Hello, Zachariah.
Can you hear me? Yes, sir. Hello?
Maybe Zach went for a potty break.
I think the volume got turned down. But we're ready.
All right, go ahead and take the audience for a tour of the operating room so they can see what it looks like in an operating room, who the team members are. So I'll go ahead and introduce the team members. So, what about the monitors? Oh yeah, don't show the monitors. You hear me, Zach? The big screen monitors, because
yes, sir.
the name is on there, and we can't hide that. So your video control has to be good. All right, we have in the operating room the surgeon, me, the anesthesiologist over there, Dr. Santiago, which will be hard for you guys to see. Shot. We have a scrub tech, and who also is our manager of our operating room, Luis. We have an x-ray tech, a nurse, circulator, and today we have a guest laser tech because we're demoing a new laser. Are you comfortable? You feel that? And of course we have the most important person in here. Who do you think that is? Our patient, that's right. Most spine surgeons would tell you it's themselves, but it's not, trust me. We're here to do a job, and the most important person is our patient. So, all right, you got a lot of bone spurs, sweetie. Let me just see what we got going on here. All right, at this point, let's go back. I've got to get the lights down so I can see what I'm doing. Good. We're in perfect trajectory. I think I'm just a little bit more medial than I want to be. Shot. A little higher. Shot. 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 So L5S1, which is the disc I'm trying to get into right now, is the hardest by far. Shot. The other ones are relatively easy, but this is certainly the hardest. Shot. And what I'm doing right now is I'm navigating by the facet joint, which is, in some people it gets very enlarged. Shot. From arthritis. Shot. And that's what I'm dealing with, an enlarged facet joint from the old injury. Shot. How long ago was your injury? Give me an AP. How long ago? Just a year. All right, so I'm actually more medial. I'm at the medial border of the pedicle. So go back to a lateral. Just what year was it? Oh. So it was over 10 years ago, right? Our patient is calculating. So I'm far away but medial, so I need to be a little bit more lateral. I'm going to restart a little bit more lateral. Shot. It's all right. Don't worry about it. I know that the injury was a while ago. Shot. It was at least 5 years ago. I think it's more like 15 or 20. But I don't have that in front of me. So when you injure your spine, you're either injuring the bone, the vertebral bodies, or the pars, which is the part that connects the vertebral bodies to the posterior elements, which are the facets. You're either injuring the bone or you're injuring a joint. Okay? And the joints include the facet joints, which are the joints in the back of the spine, and it includes the disc, which is shot in the kind of the front to middle of the spine. So injuring your spine, shot, is an injury to either a bone or a disc. It could be a ligament too that holds bones together, or a tendon where the muscles attach. But the kind of injuries that we treat surgically are going to be bony injuries. Could be a ligamentous injury, or it could be a joint problem like a disc injury or a facet injury. That's looking pretty good. Let's go with AP. So the first thing a doctor has to do when trying to figure out why a patient has a back or neck pain is to understand or figure out, we call it diagnose, where the problem is. That looks better. Is it a problem with the bones being fractured? Rare, unless you're in a motor vehicle accident or a fall. You feel any pain? I feel the herniation there. Back to a lateral. So is it a bony fracture, like a fractured vertebral body, or is it a pars fracture where now your spine will slip forward because the piece of bone that holds the vertebral bodies in alignment has been injured or damaged and it's no longer holding it in alignment? Or is it a disc injury? So today we're dealing with disc injuries. This patient has disc injuries. And disc injuries are very common. We call them herniated discs or bulging discs, ruptured discs, extruded discs, slip discs. There's about 10 different names for a disc injury, but in the end, they really are all the same. So don't get caught up in the terminology. The terminology is stupid. What matters, what really should be called is an annular tear with a herniation. A herniation is the simplest, most accurate description of what's happening with the disc. Now, there are other types of disc injuries, but they're extremely rare. And one of those is called a discitis. And a discitis is the other kind of thing that can happen to a disc. But if you look at all disc injuries in the world, 99.99999% of them are herniations with annular tears. So to get a herniation, you need an annular tear. Unfortunately, there was a publication recently, about 3 or 4 years ago, where the scientists said, to have a herniation, you have to fracture part of your end plate, which was ridiculous, totally inaccurate. To have a herniated disc, you have a tear in the annulus fibrosus. It's simple. You need a WAG, and let's get on to L45. So we're doing 4551, correct, on this side, and then 2-3. So we'll do one incision for 4551. We'll do one incision for 2-3. Nice job. That looks good. I think you're fine there. I'm talking to my x-ray tech. She's repositioned the fluoro. So the fluoro is a tool that we use in the operating room to guide the surgery, like to where we need to go. And I'll get back to disc injuries in a minute, but basically the fluoro lets me look at the vertebral bodies and figure out which disc I'm trying to get to. So we name the discs based on the vertebral body above and below. Shot? So right now, I know you can't see the sacrum, but we just saw it a minute ago, shot, and we are going to the L45 disc. The needle down below that you're seeing is the L5S1 disc needle. Now we're going for L45, the level right above L5S1. So discs are named for the bone above and the bone below the disc. So the disc below that we already accessed is L5S1 because that's the L5 vertebral body and the S1 vertebral body. Shot. Now I'm heading towards the L45 disc, and I'm just getting past the facet, and I'm heading right for the foramen. The needle tip is in the foramen, and I can actually feel, where do you feel that?
Over the back of my leg.
In the back of her leg.
How far down your leg does it go?
Going from my backside, I would say that it's the same.
3/4 down the knee, 3/4 down the foot, what?
Uh,
Below the knee or above the knee?
no, it's above the knee.
Above the knee. All right. So this is why the patient's awake. This exact instant during the surgery. You can see a herniation, right? And you can see the needle tip shot. And I'm right up against the disc herniation. And she's complaining of pain going into her thigh. Now, if she told me the pain went all the way down to her calf or her ankle, I would have to stop and reposition the needle because I'd be concerned that we're hitting the nerve. And that's the only way to tell that we're hitting the nerve besides doing intraoperative monitoring with EMG, which is certainly doable, but I think this is a better and more sensitive and more reliable way to test. So you need the patient awake so they can tell you whether or not they're getting a nerve root irritation from the needle. But I'm looking at the x-ray and we're well below the pedicle, well below the nerve root. So as long as I'm medial enough, I shouldn't be hitting the nerve root at all. But having the patient awake can confirm that I'm not hitting the nerve root and we can do the surgery safely. Now, she's complaining of some thigh pain because the disc does refer pain to the thigh. Okay? All right, let's get a AP and see where we are with the needle. So far we've lost basically like 3 drops of blood. 3 drops of blood this whole surgery. Now, had this patient had an open surgery by someone else other than me, she'd be losing by probably about 1 liter of blood for this surgery, for an open surgery. Because most surgeons don't know how to do endoscopic spine surgery. She would be losing about 1 liter of blood. All right, so the tip of the needle is kind of at the almost the medial border of the pedicle. We know there's a big herniation here. Where do you feel it? Huh?
Right across the,
But not down your leg.
no.
All right, good. Oh yeah, that went in so easy because she's got a big tear there. I mean, it literally just went in so easy. So I felt comfortable. I was in what's called Cambin's triangle. Remember who Cambin is. We've talked about Dr. Cambin. Dr. Cambin is a orthopedic surgeon that back in the 80s discovered this approach to the spine. I didn't discover it. And what I mean by that is he saw everyone. Go ahead and can you see, Zach, the incision? Or is the fluoro blocking it?
The floral's blocking it at the moment.
All right, go ahead and pull the fluoro out for a second. Just briefly. There you go. A little bit more. Yeah, you can go to a lateral. Now can you see?
We can see it now.
All right. So if I was doing the surgery the traditional way that 99% of spine surgeons do, the incision would be like this long. Okay? Can you see that? Can you see it?
Yes, sir.
I'm kidding. No, you can't see it because you're laying face down. So the incision would be at least this long, right? And it would be right here in the midline, right where this line is. The problem is once you cut the skin and move the muscle over, you're faced with this giant bone called the lamina. And you've got to remove all the lamina, all the bone to get down to the disc herniation. And that's so damaging to your back muscles, damaging to your skin, high risk of infection, complications, instability. So you're almost forced, really, due to the instability side from all the bone you got to remove, you got to just do a fusion. So by coming off to the side here, I'm able to go through a natural hole. I don't have to take any bone out. I don't have to remove the muscles. I don't have to make a big incision. I don't have to create a lot of pain and suffering after surgery. I'm doing the whole surgery through a tiny little cut. But the problem is nobody else really knows how to do the surgery because it's very technically challenging to learn, and you have to have all the right equipment. Let's go back to an AP. And the right equipment costs millions of dollars to set up a program. So it's cost prohibitive. Also, the training of the surgeons, it's going to take about a year to learn, maybe 6 months for the best surgeons, a year for the average surgeon to learn. And they don't want to take a year out of their life, fly to Florida, live here, and learn the technique. So, you know, for people wondering why doesn't other surgeons do this, like why doesn't everyone fly around in a stealth bomber? They don't have the money. They don't have the, it's not accessible to them. And yeah, really that's it. I mean, if you could, you would, right? You would fly very quickly from one place to another, very safely, very effectively. So the surgery is very safe and effective, but the problem is the access to it is very limited because there's very few surgeons or facilities that have the equipment or training in order to do it. All right, so here we go. We're going to get started on the L23. I can see it up there. We need to get L23 better centered. So you can see she has a little bit of rotatory scoliosis. We need to get the L23 as a true AP. So you're going to have to rotate. And you're going to have to, not wag, but is that hurting? It did? You felt it? All right, so I'm going to give her a little bit more local. Now for the astute people that are watching carefully, I hate giving all my secrets away. It's taken me years to learn them all. And there's people I don't want doing this procedure out there who will try to do it and shouldn't be doing it because they're only going to do it improperly. But the astute good surgeons will notice something about this needle positioning at L23. So who's watching these surgeries? You ever wonder, folks? I know the people watching can't tell, but we usually have about anywhere from 500 to 1,000 people watching these surgeries in 2019. And then over the next week or two, we get another 9,000. So we usually average 8 to 10,000 people watching these surgeries. So it's a pretty big audience, and you wonder, well, who could that be? Shot. I'm hoping it's nurses, doctors, people that want to learn about spine, the public. I'm hoping that broadcasting these surgeries will change the way the world looks at spine surgery and understand that, you know, there is a better way to do it than all the open surgeries being done today. In the United States alone, there's over 1 million spinal fusions done a year. In 2018, there was over 1 million done a year, lateral. And so my goal is to change all those spinal fusions to endoscopic surgery. I mean, I could have done a fusion on this patient, but she didn't want a fusion, and I thought a fusion was way overkill. All right, so I'm too high with my needle placement. We're skipping a disc, right? We're not doing L3-4. We're just doing L4-5, L5-S1 plus L2-3, which is what I'm heading to now. Let's get those end plates lined up just a little bit better with some wag. Shot?
We have a question.
Yep. That's good. I think that's good. The pedicles are lined up nicely, so I think that the end plates look good. Shot. I'm right on the facet. Yes, Zach, what's our question?
We had a viewer who said, I had a 2-level fusion.
Shot.
L45, L5-S1. I'm now having bad pain in my hip joints. What are some possible causes for that?
Okay, where did you feel that?
Right in the, like in the middle of it.
In the back?
You felt it in your back? Shot. Yep, we're right at that next painful disc. All right, we have one of our viewers saying, I've got a fusion at L45, L5S1, and I'm still having pain in my hips and my back. Shot, what are some of the causes of that? Well, there's great question. We actually get this question shot quite a bit, unfortunately. But the possible causes include, number one, adjacent segment disease. That means that the joints above or below your fusion are now causing pain. Very common cause. Probably number one in my book. Not for me personally, but that's what I would expect as the number one reason. Adjacent segment disease means that the joint above, which would be your L3-4 joint or disc, and the joint below, which would be your sacroiliac joints, those are the actual causes of your pain. Or your piriformis muscle in your buttock, right? So any of those things could be a cause of your symptoms. We call it adjacent segment disease. It means the joints above or below the fusion. All right, the other cause could be an infection. So you want to make sure that your doctor has checked you for that, rule it out. Another cause could be failed fusion. In other words, the fusion didn't take. I need someone to get my microphone wire off my back of my neck. It's pulling on my mic. I'll come to you. So failed fusion. In other words, the fusion that you supposedly had with L4 being fused to L5, L5 being fused to S1. Remember, fusion doesn't occur in the operating room. We call it a fusion, but it's your body that actually has to fuse the bones together. A fusion is when the bone above and the bone below come together and form a bridge of bone, and they make one solid bone. So we are trying for you to fuse. That's why we do the surgery as a fusion. But if your body doesn't fuse because you smoke or you have bad bone metabolism, you use a lot of nicotine products, or just bad luck, or you've got your screws are too skinny, or your screws break, or your screws get loose, or your cage is too small, any of those reasons, not enough bone graft, they didn't prepare the end plates well enough during surgery. I mean, there's a litany of reasons why a fusion wouldn't take, but it's definitely a known thing to happen. And the more levels of fusion a patient has, the higher the risk of failed fusion. So the risk of failed fusion for a one-level fusion may be, 10 to 20%, depending on which discs are being fused. But the risk of failed fusion goes up with the number of levels fused. So those are just a few of the reasons. You could have a fracture as well, in your spine, either above or below your fusion. I mean, really, it could be muscles. I'll tell you something. One of the things that bothers me the most about other surgeons and the way they do fusions different than me is they destroy the muscles back here in the back. If you're doing surgery on this patient, you do open, you compress the muscles for too long, the muscles all die. So literally all the muscles here would be dead. It would be scar tissue instead of muscles. That scar tissue replaces the dead muscles. So when I do a fusion surgery, I make sure I don't kill the muscles. I protect them. My patients have about 99% of their muscles are there when we're done with the surgery. But every other spine surgeon I know doesn't care about the muscles. They don't think about the muscles. They just move them over and don't forget about them. And they end up after surgery killing all the muscle. Well, if the patient's muscles are all dead here, they're going to have pain back here because their muscles up here get tired. Your muscles, think about it as a crew on a ship. If you need 10 people on the oars to make the ship move and you get rid of 80% of them, you have 2 people left, those 2 people have to work much harder to make the boat move. So they're going to be sore, tired, they're going to give up. That's why therapy is so important. So there's a whole laundry list of reasons you could be having pain, but I can tell you this, about 95% of those reasons are completely fixable, but you need to go to the right doctor and the right facility. Deuk Spine Institute can definitely help you. All right. Are you comfortable? You remember this part from last time?
Yeah.
Wow. How bad is that on a scale of 1 to 10? Huh? 9 out of 10. All right, that was the 9 out of 10 for the L23 disc. I mean, she has such a big tear that literally I couldn't even pressurize the disc. It took the whole load of dye. So That was impressive. In other words, the disc is very damaged, but don't worry, we're going to fix it. You're doing great. We're going to have you asleep in just a few minutes. Okay? How bad is that? All of her discs are just blown out. What was the worst it became? 7? 7/10 at L5S1. Did you feel it go down your leg at all? Which leg? Huh? That went down your left leg? So the opposite of the side I'm working on. So it must have leaked out the other tear that's still healing. Very interesting. Shot? Left leg? Or right leg? Left leg. Wow. I mean, she's taken an entire syringe of contrast for each disc. So now this patient's had laser surgery before on the opposite side. So those discs are still healing, but you can see they're not completely healed yet. How long does it take for a disc to heal? How bad was the last one?
What's the number of the last one? Huh? Thinking?
The one I just did. Where you, just give me one number, the highest it went. 5. So that was what was that, L4, 5? Now look at that picture. That is amazing. So you can see the dye has leaked out on the opposite side of the needles. Yeah. So you can see that, like at L4, 5, for example, there's still a tear, and that's healing, and it should continue to heal, but she just had that side laser surgery like a month ago, and so it takes a full year for the disc to heal. But that just highlights the fact that the disc doesn't heal right away from laser surgery. You need to give it time to heal. And I always tell people it takes a full year to heal. All right, we're going to put you to sleep, okay? Count out loud from 1 to 100 by ones. Start at 1.
Are all those results considered concordant?
Yeah, they're all concordant. Shot. I'm starting at L4, 5. All right, good. Shot. Yep. So I'm removing the needle over the guide wire. Now, just so people know, watching my videos of how to do the surgery does not constitute a training program. So don't get any ideas that you can watch my videos and start doing these surgeries. You need to be trained properly. I make this stuff look very easy. It's kind of like when you're watching the cooking channel. They don't show you every single step. Well, I'm showing you every step, okay? But even though I'm showing you every step, there's things that you can't feel like that I feel. Like I know, for example, I'm on the disc because I can feel it. So you guys don't get the benefit of that. She's moving because it hurts. Yeah. Huh?
I'm adjusting her face.
Not a problem. So we're right on that painful disc at 045, and it's definitely bothering her. You can see her moving around. So she said this was a 5 out of 10, but I think it's a lot worse than that. I think that the reason it's not like registered with her as a higher pain level is because it wasn't able to hold the pressure because it went out the other side that we already repaired. Any questions, Zach?
No problem. We were asking,
Lay still.
is there a difference in surgery outcomes or recovery time based on how much blood loss? Say if you lost 500 milliliters.
Shot. So one of our viewers says, well, Dr. Deuk, in surgeries where patients lose 500 mils of blood versus just a few drops here, like 2 mils of blood, is there a difference in outcomes? The answer is yes, there is, because you need blood to heal. You need blood for so many reasons. Is that where we are right now? Okay. You need blood. But think about what does blood do? Okay. Number one, it lets your wound heal, right? Your wound that we're creating, the incision in the skin, the disc that's been repaired now needs to heal. you need red blood cells to do that. Red blood cells carry oxygen. Without oxygen, your body cannot heal that wound. That's why people who have trouble healing their wounds, they go into what's called a hyperbaric oxygen chamber. That's where they get extra oxygen, more than is in the air that we breathe. That's because they need extra help. So oxygen is so important to wound healing and healing these discs. Shot? So when you lose more blood, you have less red blood cells. Your oxygen carrying capability of the blood is reduced. Okay? Number two, your risk of infection goes up. Why? Because you're not perfusing the area that we're operating on. And you could have, bacteria are pretty much everywhere on our skin. So we do everything we can to reduce the risk of infection. Infection basically is, simply put, bacteria entering the body cavities and starting to grow where they shouldn't be. Now, it's normal for bacteria to grow in your skin. That's for sure. And it's normal for bacteria to grow in your colon and your mouth and on your tongue, but not within the realm or confines or borders of your body's natural tissues. So your gut, where if you eat a piece of food, like let's say you eat an apple, that apple material goes from your mouth down out your anus eventually, but it passes through your gut. That apple is not really inside your body, it's still outside your body. That's where we are? All right. So that gut can have bacteria in it. Now, you don't have bacteria in your stomach, you shouldn't. If you do, it's Helicobacter pylori, it's bad, creates ulcers. But because the stomach is too acidic. But, I guess what I'm trying to say is you need your blood supply to bring the immune cells and inflammatory cells that we need for healing. You need your blood supply to bring red blood cells to carry oxygen so that you can heal your wounds. Okay? So losing blood is always bad in surgery. And you want to minimize the amount of blood loss. You lose blood, you also affect your temperature regulation in your body. Okay? Low blood pressure from blood loss can also cause, vasospasm. It can cause a strain on your heart. And so the heart strain is one of the most important. So your heart muscle, as it beats, your heart consumes tremendous amount of oxygen. Okay? Your brain does as well. But the brain consumes the most amount of oxygen per minute. The heart is the second most, the kidney is the third most. And then it goes down from there. So your heart, your brain, your heart, and your kidneys are the three most sensitive tissues in your body to amount of oxygen that's available for them. And when we do surgery, we're not stopping the heart from working. The heart is beating, right? And so, thank you. Yeah. So basically, the heart needs that blood. It needs the oxygen. And if you don't have enough oxygen, what happens is the heart starts beating faster. Right? It starts pumping faster, trying to get oxygen. So people who lose 500 mils of blood during surgery, or a large amount of blood during surgery, is going to strain their heart because the heart's beating faster, faster, faster. It's not getting enough oxygen to the tissue of the heart, and that's what precipitates cardiac failure, heart attacks, all that good stuff, right, that you don't want to happen. So blood loss is massively important when it comes to the stability of the cardiovascular system and the risk for having a heart attack or even a stroke after surgery. Also wound healing. And then, of course, there's a lot of nutrients in the blood. And if you're losing 500 mils of blood, you're also losing the electrolytes, so potassium, sodium, calcium, and all the nutrients and vitamins. So you don't want to lose blood, period. And anytime you can avoid losing blood in surgery, it's really, really beneficial to the patient. So the endoscopic surgery right now, if you look, we've lost literally 1 milliliter of blood. 1. And if we did open surgery, not me because I'm very good with minimizing blood loss during open surgery, I would lose 100 mils if I did a 4-level fusion, maybe 150. But the normal spine surgeon out there will lose 1,000 mils for this 4-level fusion, okay, which is the alternative surgery. So yeah, the laser is 1,000% better with respect to blood loss, which is all about safety and success of the surgery for the patient, okay? I hope I was able to answer that. There's other things too that I didn't talk about because it's just too long of an answer. You could write a textbook about it. Right, doctor? Okay, guys, I need that laser on. All right, I don't have enough cable here. Okay, are we good? What's the problem?
No, I can't reach right now over there. So that's fine with you?
It's okay, yeah. You got to give me a little more length on the cable. All right, we've got the laser fiber here. And you got to set it up properly in the beginning because now you're pulling unsterile onto sterile. It's bad. Okay? Never want to do that. You'd rather go the opposite way. You'd rather have him pull sterile to unsterile rather than unsterile to sterile. Okay? And I'm just worried about this angle here for this. Otherwise, I can do it, no problem. So right now, you're watching through the endoscope, through that tiny little metal straw that I put in to connect the outside world where we are to the inside world inside her disc. And there's a big tear right here in the disc. We call it an annular tear. And this is, of course, on her right side, and we are at L4-5. So she has a large L4-5 tear. Now, why didn't I fix this with her first surgery? The reason is simple. She had too many herniations and tears to fix in one surgery. It's only safe to really do four points at a time. She needed 7. So we maximized her first surgery, and we did 4 on the left side, and now today we're doing 3 on the right side. She didn't need a 4th one on the right side because there's no herniation at L3-4 on the right side. It was only on the left side. So she did really well after her first surgery and had excellent relief of pain on her left side from the first surgery.
I think you did the 4 levels through 1 incision on this.
Yeah, and if for those of you who were with us a month ago, we did the 4 disc levels with 1 incision, which I did not do today. I actually did 2, which is fine. I mean, in the end, it's tiny. And we could probably show you folks the 1 incision at the end of the surgery. I'll have Luis take the drapes off. I think it's running down my hand. So any questions from our audience? I know Sue Griffin is probably out there watching. Hello, Sue. Sue is a friend and a patient, and I was talking to her very early this morning when I was up working, and I know Sue is probably wondering. She asked me, you know, what are you doing with coral? I was explaining to her what I do with coral. So coral is it's basically an animal. It lives underwater in the ocean. It lives in the shallow parts of the ocean. And anytime you see pictures of fish, saltwater fish in the ocean, you probably see them on a coral reef. And coral reefs are incredibly complex and old ecosystems that have been around for hundreds of millions of years on Earth. And they're believed to truly be the crucible of life. We really do believe life began in the oceans and moved to land. And, you know, began with basically the formation of coral reefs, very complex ecosystems with lots of organisms. Anyway, corals are absolutely beautiful. And they produce what's called fluorescent proteins. And the fluorescent proteins make them glow under blue light or black light. So there's a lot of people that grow coral and keep coral, and they love to look at it because it's like living art. It's literally, in my opinion, one of the most beautiful things in nature to look at. But most people don't know that, and they can't appreciate it And the reason the public doesn't know about it is two reasons. Number one, it's in the ocean, so it's nowhere near where we normally live on the surface of the earth. But it's also incredibly difficult to grow coral properly to where they're healthy and beautiful, and then to light them properly, and even to photograph them is almost impossible. So most people don't know much about coral. Anyway, the problem that's happening is the corals are dying all around the world. And for the longest time, everyone thought it was the temperatures of the ocean, it was microplastics or whatever. But all these theories were never proven, and they were just theories. 1 year ago exactly, I discovered the true cause of coral death in my free time as a neurosurgeon and CEO. And that cause, it turns out, it's an infection. An infection. And it's actually an infection not by a bacteria, which is what some of the marine biologists thought it was. It's not an infection by fungus. It's not an infection by virus. It's an infection by the one microorganism they never considered, but I discovered to be the cause of coral death, and it is what's killing the coral reefs around the world. But I'm literally the first person in the world to make the discovery and to talk about it. And it's kind of like that person who first went around the earth and came back and said the earth is round, it's not flat, when everyone thought the earth was flat. And of course, when he came back off a boat and started to announce that, everyone wanted to grab him and hang him, right? But they wanted to maybe torture him a little bit first. So that's kind of where I am in the world of marine biology. I'm the outsider who discovered something of greatest significance, but the people that are in the marine biology world that have been basically have failed to figure out what's killing the corals all these years are now shocked. But a year ago when I made the announcement, everyone wanted to find me and tar me and feather me. And now the leaders in the field, the hobbyists, are starting to understand what I've told them is true, that it's an infection by a protozoan called philaster. And it's a very, very specific protozoan. It's long and skinny. Its body is about 150 microns long. It's about 75 microns wide. It's a single cell organism. It swims very, very well in salt water, better than any fish. And it literally can swim 10 times its body length within a second, or a fraction of a second. And it's able to change directions. It's able to find coral and infect coral through its opening in the polyp. And of course, I've discovered all these facts about it myself, and I've been publishing it, and it's on a website called Coral RTN. RTN, it stands for Rapid Tissue Necrosis.com. That's one of our educational websites to educate the public about the problem. But the issue is it's an infection. So it's kind of like people that used to get AIDS, right? We didn't know why they were getting all these nasty, weird diseases, and then somebody figured out they've got a viral infection with HIV, human immunodeficiency virus, right? So once the scientists figured out that HIV, a virus infection, was the basis of AIDS being the disease or cluster of diseases, I mean, now the whole world changed. Now we knew what we were dealing with. We were dealing with a retrovirus, so we started looking for cures. And it's contagious. That's the other thing about HIV and AIDS, is it's contagious. So it's spread from contact, usual sexual contact, or blood transfusion. So if you're not making contact, the lights are too bright. We need to bring it down one notch. If you're not making contact, laser off, with somebody with AIDS or HIV, then you're not going to get the virus, right? You're safe, and that's true. So of course, now that I've discovered the corals are dying from an infection, what the world needs to understand is we need to treat it like an infection. We need to use quarantine for corals that are infected, get them away from the healthy corals so they don't make contact. And it's not coral to coral contact. This parasite swims in the water. So if they're sharing the same water, which everyone keeps their corals in the same aquarium, one aquarium, then the corals are all going to be infected. And so this is a massive discovery on a worldwide scale. It's epic, but getting the word out and getting people to understand it, agree with it, and then of course start to change the way they care for corals and culture corals is going to be over the next 5 to 10 years. But there's still a lot of people who don't believe at this point. It's like people who think that the AIDS disease complexes are a sign of God because you've been sinning too much. That now you're cursed with all these diseases that come with AIDS. Well, that's complete hogwash, nonsense. It's the same thing with the Black Plague. 1,000 years ago, everyone thought that the Black Plague was caused from God punishing people who deserve to be punished, sinners. And so, of course, that wasn't the case. It turned out to be an infection with a bacteria or protozoan. I'm not sure which one it is. I can't remember now. Or leprosy. Same thing. Leprosy is a disease caused by an infection of tissue with I think it's a protozoan as well. So, same thing with malaria. Basically, every disease of animals and plants in the world has a basis. And that basis is not religious or secular. It is an infection, usually, or a deficiency of a vitamin or mineral. So, long story short, Sue, I discovered what's killing corals worldwide a year ago in my lab at my home, and now I'm trying to work on a cure, and I've been working on a cure for over a year. And what I was doing last night was running what I believe to be one of the few final experiments that I'm running probably over the next month to fine-tune the cure for the disease. So not only have I discovered the disease that's killing corals worldwide, which is epic, but now I've also had to discover the cure because very few other people understand it or are capable of doing it. It's funny because I started doing research in a lab when I was pretty young in college at UC San Diego. And doing research in a lab is, I think a lot of students that want to go to medical school do it because they want to go to med school and they're told that that's a good thing to do. I mean, that's why I did it. That's why I started at UC San Diego. I was told by my roommate, Deepak Sampath, who turned out to be now works for the pharmaceutical industry. He's a research chemist and molecular biologist. Deepak got me into a lab at UC San Diego, and the lab was underneath a principal investigator whose name was J. Siegmiller, Seegmiller. And Dr. Siegmiller was a world-renowned researcher, lab researcher for Alzheimer's disease. And his main person who ran his Alzheimer's disease lab was Dr. Nazneen Dooji. Naz Dooji. We used to call her Dr. Dooji. Anyway, Dr. Dooji accepted me into the lab as a sophomore at UC San Diego. And I started out by cleaning the petri dishes and cleaning the graduated cylinders, Erlenmeyer flasks. And once I showed that I could clean basically the dishes well, I moved up to making stock solutions, right? So they used a lot of solutions in the lab to do their research on basically beta amyloid precursor protein for Alzheimer's disease. And so I started making all the stock solutions. And once I showed that I could do that well, they started to let me run some gels. These are SDS gels, and basically to separate proteins out. And so I would set the gels up and add the proteins and run the gels. And then gradually I got into doing more and more stuff. But that was the beginning of my research time, was as an undergrad sophomore at UC San Diego, in a lab for J. Siegmiller. And I went from there to then doing research once I graduated. When I went to USC med school, I did research on epilepsy in brains, and we were using a rabbit model, and I was with Dr. Lou Cornacchia out of UC San Diego. He was a neurosurgeon. He was NIH funded, and I did all the surgeries basically. I would put a window. I would have to remove part of the skull and expose the brain, and I would put an optical window to study the cortex. We use these depolarization sensitive dyes on the surface of the brain that would change colors as the epileptic activity occurred. And we could optically record it and study basically the wave or depolarizations as they occurred, and studied their distribution or spread. So, I got into that, and then ended up doing some research at Children's Hospital of Los Angeles with one of the researchers over there, and eventually got my own NIH grant to do research when I was a neurosurgery resident in I think it was my 4th year. Yeah. So I got a 2-year NIH funded grant as the principal investigator to study epilepsy, with Dr. Stephen Roper backing me as my faculty mentor. And I did my research on basically inhibitory interneurons within the cerebral cortex, and doing stereological counting in a model of epilepsy. And one of the causes of epilepsy is cortical dysplasia, which is an abnormal formation of the cerebral cortex, which is the part of the brain where all the neurons are. It's responsible for most of your higher level functioning, like thinking, movement, etc. Anyway, I received an NIH grant to study the inhibitory interneurons' roles in epilepsy in cortical dysplasia, and we used the rat model of irradiated in utero rats to do that. So I had to do all the steps of the entire project, and I published the paper as a result of 2 years of being funded by the NIH. And that paper is still being referenced today. So there's probably only 2 neurosurgeons in the entire country that have ever gotten NIH grants as residents, and I'm one of the 2. So it's a really, really high honor that our government would see my project as worthy of funding. It's almost impossible to get NIH grants, and I got it as a MD resident in neurosurgery. So anyway, all that experience in the lab that I've had over the years, really I've just taken that and applied it now to coral research, and making discoveries every day about this philaster and its role in coral disease, and it's massive. I have absolutely no doubt. I've actually proven it using Koch's postulates. So anyway, that was a little digression on what I do for coral, and hopefully my work will be used to find a cure, if not by me, by other people, and basically save the coral reefs of the world from the infection by philaster protozoans. Now, what I've been doing here with the laser is removing the herniated disc that's coming out through the annulus. That's what you're seeing at the bottom of that metal tube. That's the torn annulus. And the tear is literally right here, and it goes all the way through down there. That's all tear. So the annulus was torn. When she injured her back, she burst her annulus, it tore, and the jelly in the center, way down there, squeezed out through that tear and just wedged itself in. And over years and years, the body has been trying to get rid of that jelly through an inflammatory process. That's how the body heals, with inflammation. So the body has been hitting this stuff right here with inflammation for years, and that's why this patient has had so much pain. Well, when you have inflammation, very young inflammation creates tissue that's very special, that's not normally found in an adult. It's called granulation tissue. And granulation tissue is young inflammatory tissue full of blood vessels and fibroblasts, macrophages, polymorphonucleosides, and also something very important that very few people know about or talk about, and it's called free nerve endings. And free nerve endings are exactly that. They're unmyelinated nerve endings that are very sensitive to pain and chemical stimuli. And chemical stimuli are found in abundance in inflammation. So basically what's happening, and I've discovered this as well, nobody has taught me this, I had to discover this fact. What's happening, what causes disc pain is the inflammation in the annulus. Again, I discovered that fact years ago, and I published it in 2012. Well, this inflammation causes the ingrowth of granulation tissue with lots of little nerve fibers. And those nerve fibers, that's where pain comes from. They're type 4 nerve fibers or class C nerve fibers. These are pain fibers. And that's why these people with herniated discs have so much pain. Because they have all these little, you can't see them. They're too small to see. You need to have special stains. And we're not seeing them here, but they're basically microscopic. Not endoscopic, but microscopic. And remember, an endoscope only magnifies about 3 or 4 times. A microscope magnifies 40 to 100 or even 1,000 times. So an endoscope is not a microscope. A real microscope, a light microscope, will magnify usually 40 to 100 is what most people look at. A surgical microscope that I have here as well will magnify about 2 to 3 times. So a surgical microscope is not the same as a light microscope that scientists use in the lab. So don't get the two confused. But you can't see nerves, little nerve endings. You can see big thick nerves, and we'll show you one in just a few minutes, because I'm going to show you her L4 nerve root as it leaves and goes into the neuroforamen here at L4-5. I'm going to show you that nerve root in a second. And that's big and thick and white, and you can see it. But, thanks, the little nerves that you get in granulation tissue you cannot see with your eyes, not with the endoscope. You need special stains, and you need like either an electron microscope or a very high-powered light microscope with the proper staining. Remember, there's no myelin sheath over the free nascent nerve fibers in granulation tissue. And that's because they're unmyelinated fibers. They're new fibers. Think of them as like the new roots of a tree, right? Old roots have a certain appearance, right? They almost have like a woody appearance to them. But new young roots are very delicate, and they look different than old woody roots. Mike, making sense to anybody?
Yes, you are.
Thank you. Anyway, I love medicine and science. I just naturally gravitated to them. Why? Honestly, science is just pure. It's pure logic. It's pure fact. There's nothing subjective about it. You know? My daughter was on the United States national dancing team, and we lost to Japan this year, right? In the finals. Took number 2 in the world. Japan took number 1. Nothing against Japan. Great dancers. But they did not have the routine we did, and honestly, if you look at the points, they never should have won. I need a laser on. But they won. They won by less than 1 point out of 100. They won by 0.7, I think it was. But if you look at their routine, there was no complex moves. So in other words, what I'm getting at is, even when you know you should have won, if it's subjective and it's up to judges that are human, that make errors, or can be bribed, either way, it's just something so ungratifying about that and disappointing about it. The thing about science that's so wonderful is you'll never be disappointed only in yourself. If you fail yourself, then you have to be disappointed in yourself. So in a way, science is truth. It's about being honest with yourself. If you study and learn science, then you can answer lots of questions about the world and how it works and solve problems. if you study literature, it's interesting, but you're not going to really solve any of the problems of the world by studying literature. And I'm not trying to criticize literature or music. You know, those are wonderful things, and my son is a musician, my daughter's a musician, and I think it's one of the most important things they do, but it's not fact, you know, and people, it's open to interpretation by others. And anytime you get into arts which are open to interpretation by others, you kind of lose, I think, grounding in reality, and you potentially can, it gets very weird, and sometimes for most people it's going to end up being disappointing. There's a piece of granulation tissue right here. It's kind of pinkish, if you can notice a difference. All right, take this. You have a question, Zach, it sounds like?
We do have a couple questions.
Sure.
We were asking, could stem cells help repair the damage caused by discitis, which was caused by an infection in my L4 and L5?
So, that's a really good question. Can stem cells help repair the damage that was caused by discitis at L4, L5 that I had in the past? So let me try to answer it for you. First of all, I'm just going to give you the short answer. The short answer is I don't know. And I say that only because I'm not going to sit here and lie to you or anybody. That's not part of this broadcast. This broadcast is about truth. And I believe in telling people the truth. And the truth sometimes is that we don't know the truth. We don't know the facts. Nobody knows. So the answer is nobody knows the truth about whether it would help. Because, thank you, it's such an unusual thing, okay? I have seen discitis probably 10 times in 20 years. That's how rare it is. But discitis is actually, for those of you who don't know what it is, it's inflammation of a disc. And we believe that it's usually caused by infection. However, many times when the doctor looks for the cause of the infection, we can't find it. Stand by. So we got a herniation there I need to get out. It's blocking my view. So we believe discitis is mostly infectious, but sometimes all the tests we do don't show what causes the infection. I personally believe it's infectious, but sometimes you can't prove it because you don't have the bacteria that you grab out of there and it grows on a petri dish, because sometimes it just doesn't grow. And I'll tell you why. There's various reasons why you sometimes can't make a diagnosis as to the cause of discitis. That's because a lot of times when the emergency room doctor sees the patient, look at the granulation tissue right there. You see that pinky color? Pretty cool, huh? That's where the pain is coming from. All right, as soon as I grab the laser, just turn it on, please. No, don't hesitate. I've been doing this for 15 years. Okay? Yep, don't worry. I'm a neurosurgeon. I'm not going to fire it inside the tube. If you were talking to a 6-year-old, maybe you would worry about that, but I'm not a 6-year-old. I'm a very experienced neurosurgeon. But thank you for your concern. All right. Anyway, discitis, a lot of times patients come into the emergency room, and the first thing the ER doctor does is they give that patient antibiotics. Right? Oh my God, you got an infection in your back. Here's some antibiotics. So then the patient gets antibiotics, right? And then by the time the neurosurgeon or interventional radiologist gets to the patient and starts trying to get some of that disc material out so they can culture it and see what's growing, they've already had antibiotics. So of course the culture is going to come back negative because the antibiotics are killing the bacteria in there. So one of the reasons is just, bungled management of the patient. That's why a real good neurosurgeon will get in and see the patient, and nobody will give any antibiotics until he gets a piece of that disc. And then you grow it in a petri dish and it'll grow out some bacteria usually. So that being said, discitis is mostly a really bad inflammation of the entire disc, and it's very painful. Now, once you get rid of the infection with treatment of IV antibiotics for 6 weeks or 8 weeks, sometimes it's 3 months, now you no longer have discitis, okay? And so what our viewer is asking is, well, what if you do stem cells then. Will that help? Well, what stem cells do is they promote inflammation. All right, so you'd be promoting inflammation in a disc that already had a lot of inflammation. Right, that's what discitis is inflammation of the disc, massive inflammation. So will that fix the problem? I don't think so, but I'm going to be honest with you, I don't know the answer to that question. And I honestly don't think anyone does, because I don't think anyone's ever put stem cells in a discitis disc. Now, there may be some doctor out there that has, but I guarantee you that they've only done it like maybe 5 times at most. At most. So I would say it's an unanswered question, but if I had to choose based on all the knowledge and experience I have, I would say it's not going to work. I would say that the stem cells will not work for treating pain from discitis, whether it's acute or chronic. I think your best option is exactly what you're watching right now, the laser surgery. Go into the disc and remove the painful material causing pain. That's going to be your absolute best surgery. Right here, what you're watching. Deuk laser disc repair. All right, next question, Zach. We're just about done here. That's why. All right, so after surgery, will I be able to lift heavy things again? Not a problem. I'm kidding. Not a problem for me, because I'm just doing the surgery. But as far as the patient goes, yes, you will be able to lift heavy things again. And it's going to take a year for that disc to fully heal. So I recommend to all my patients that have this surgery, don't lift over 25 pounds for the first 6 weeks. Then, if everything's going well, which it will be, I recommend 40-pound lifting restriction. So up to 40 pounds for 1 year. And at the end of the year, then you can go to lifting whatever you want. But understand something. The human body is not really made to be lifting heavy things. But yes, you can certainly go back to lifting heavy things. So if I had an injured worker who was required by their job to lift heavy things, I would say they need to take enough time off to allow their back to heal to a point that they can go back and do their job and try to find a way to minimize the amount of lifting until they get to a year out. But the nice thing about this surgery, folks, is if you have a disc herniation and you're having disc surgery, if you have a microdiscectomy, which is what most surgeons around the world will offer you, that's not going to fix your back pain. It's only going to help with your leg if it's done properly. This surgery you're watching here, the Deuk laser disc repair, is better than a microdiscectomy because we do fix back pain and leg symptoms, both. The microdiscectomy only fixes the leg. It won't fix your back pain. So the other thing about a microdiscectomy is it's going to definitely cause weakness of your spine. Your spine is going to get weak where they did the surgery because they got to remove bone. And removing bone always weakens the spine. Your surgeon may not admit it to you. People may not want to talk about it. But it's a known collateral damage to a microdiscectomy. Is if you look carefully at the procedure and you look at the words very carefully, you'll see it says laminotomy. A laminotomy is removing bone, okay, to get down to the disc herniation. It'll also say partial facetectomy. Your facet is a joint in your spine. It literally holds your spine together. So partial facetectomy, ectomy means remove. So your surgeon's actually removing part of a joint that holds your spine together. Now they're not going to tell you this because they don't want you to go running when they talk about a microdiscectomy, but I would never do a microdiscectomy on my back. No way. The surgery you're watching now, we don't take any of the bone or joints out. And that's, well, again, it wasn't my discovery to do this surgery, to go through a natural hole. It's Dr. Camden's discovery, and I give him credit because he's the first one to do it back in the 70s and 80s, but at the University of Pittsburgh in Pennsylvania. But he had a lot of complications with his surgery because he didn't have the special tools that we have now, like lasers and stuff. And the laser makes all the difference in the world. people say, and if you've noticed, if you've been watching this whole surgery, all I've done is use the laser. I may have put the grabbers in for a few seconds, but 99% of the surgery is done with a laser. And that's another unique thing about my surgery, is I'm the only surgeon doing surgery where 99% of the surgery is with the laser. Most other doctors, they use metal grabbers, or they use radio frequency ablation, which doesn't work as well. The laser is the best by far. That's why I use it. It's just hard to use properly, and you have to be trained, and these doctors don't know how to use it, so they kind of laugh about laser. Oh yeah, laser doesn't work. I get people all the time writing me letters saying, oh, my doctor says laser doesn't work. Well, that's because your doctor doesn't know how to use a laser, so he's right. Laser doesn't work for him or her. Okay, let's take a look at the nerve. There's the nerve to the basically 3 o'clock position. There's a lot of there's a vein right there. There's some fat in there, but the nerve is right over there. It's the white thing on the right. It's got some fat around it, but you can see the herniation's gone that was pushing on it. So now there's a little hole there, and that hole will seal off. There's a little bit more herniation right here I just want to get. So underneath the nerve root. I need the laser on. Perfect. I'm very happy with that. I've had other surgeons lie to my patients, and I have a patient who comes and says, oh, I want the laser surgery, it looks wonderful. Yeah, it's perfect for you. And then they go and tell their surgeon who doesn't do the laser surgery or endoscopic surgery, they're going to go have laser surgery, and the surgeon will literally do whatever they can to keep the patient so that they can do the surgery themselves. And they'll lie to them and say, oh yeah, laser surgery is great, but just not for your problem. Yours is different. It's amazing what, like I said, I have zero respect for most surgeons. I didn't start that way, laser off. I started out with tremendous respect for doctors, but I found out that a lot of them are just dirt bags. Sorry, but it's the truth. And they deserve really that comment. All right, so huge disc herniation gone, but there's still the hole there, and that will seal off over the next few months. Okay? We're done here at this disc. There's nothing else to take out that needs to be taken out. I'm going to suck the water out. Yes, I'll take the question. Stand by. Will the laser work? Absolutely, it'll work. But the laser works on herniated discs. So what I would need to figure out for you is what's causing your fusion to be failed. Is it adjacent segment disease? Is it residual stenosis at the level treated? Is it failed fusion as in the bones are wiggling around and the screws and rods are broken? Is it nerve root compression from stenosis? Is it a discogenic problem? Is it a facetogenic problem? So I can definitely help you, and we don't have to do another fusion at all. But I need more information, which you cannot provide me over this computer. I need to actually do a physical exam on you. We can do that through a teleconference usually, a video teleconference. So send in your MRI report, or your MRI would be even better. A CAT scan would be good. And then I'll look at those pictures personally, review them, and then we'll do a video conference if you're far away in another country, or even far away in the United States. We can do a video conference, and we can chat about what could be done to fix your problem. Okay? We can do a lot without you actually flying to Florida, or anybody flying to Florida. And we offer these services to everyone, every single human being alive. If anyone wants me to review their MRI, I'll do it. If anyone wants to do a video conference with me and talk about their problem, we'll give you 15 minutes free over the internet. You just have to get access to Skype or one of those platforms that allow you to talk to me. Why do I do it? I do it because I want to help everyone get better. I want everyone to be out of pain. So it's part of my vision and dream, basically to cure back and neck pain in the world. And I just do it one patient at a time, one person at a time. So, huh? Yeah, 5-1 is next. Yep, do whatever you need to do because there's a little bit of scoliosis, so we got to wag the floor. Now I'm putting pressure here on the muscle, and the reason I'm doing that is I don't want a blood clot to form. So if you put pressure on the muscle, you stop the venous bleeding out of the vein into the muscle. And that's what I'm trying to do here. All right, so the table needs to go up a little or fluoro down to the ground. Okay, table up a smidge and go north a little bit. You're too far south, I think. Just a little bit. Shot. I just want to minimize how much hips we get. And then, it's kind of hard for me to tell, but it looks like we're still rotated a bit on the x-ray. Other way, maybe. I think it's worse. So, I don't know if I answered that question entirely, but we can definitely help you if you're having pain either in your back or down your legs or even in your neck and arm from a cervical fusion. We can definitely help you. That's good. I just need more information. And if you provide us those studies, then I'll do a video conference with you for free, and you can get my opinion on what can be done. But if your problem is adjacent segment disease at the disc above or below, probably below if you're at L23 before, then yeah, we can definitely take care of that herniated disc with this laser surgery. And we have actually quite a few people who travel from around the world. They don't want to have another fusion done. They want something different, so we do the laser surgery for them. Shot. All right, so what I'm trying to do is advance the dilator along the guide wire. And as you're doing that, just be careful. If you're a surgeon, be careful not to pull your guide wire out. If you pull your guide wire out, you got to start over again with positioning using the needle. You have to wake the patient up as well. So don't pull your guide wire out. Shot. Also, don't advance your guide wire accidentally, push it in more while you're doing this either. If you push your guide wire in, you're going to end up in the pelvis where your colon is. If you puncture through the colon with your guide wire, you're going to get an infection inside the patient's disc and inside their pelvis, which is bad. So like I said, I make this surgery look very easy. I don't talk about all the little things I'm doing, but understand that it's extremely complex surgery. And if it's not done exactly right, there's huge consequences in terms of complications for the patient. Shot. All right, I hear you have another question.
We were asking, the discs become herniated again after the surgery?
Oh, great question. So one of our viewers says, can the disc become herniated again after the surgery? 100% yes. Because we're not taking the disc out, we're only taking the little piece that's herniated out, and because you still have movement at that segment, you can definitely herniate the disc again. And that's why I tell all my patients to wear a brace religiously, wear a back brace or neck brace for 6 weeks, and then also not to lift anything over 25 pounds, and then to avoid contact sports until their disc is healed. So 100% you can re-injure your disc. Remember, we're not fusing and we're not taking your disc away, so you could re-injure it. Now, if you follow my instructions, you won't, unless you fall or get into a car accident, which I can't help, and neither can you, but then you can re-injure it. Now, what's the chance with this surgery? What are my results? What's my record show? My record shows that 1 in 100 of these will re-herniate to where they need another surgery. So that's 1 out of 100, 1% chance that you will have this surgery and you'll re-injure your disc. But I can tell you right now, as long as you follow the lifting and bending and restrictions after surgery, you should be fine. You won't have a problem. Great question. 1% chance of reherniation to needing surgery. Shot. Again, massive, massive tear. I mean, this is going in so easy. So that means there's a giant tear in the disc. Giant tear. I mean, it just went in so easy. So, shot. That's it. All right, let's get the fluoro out. We're going to do L5S1. That's the next disc, and then we're going to wrap the surgery up by doing L23, which, remember, we already did all the needles, so we're ready to go. Great questions, by the way. I love answering the questions. Coral question, I love it. Yeah, do it.
We were asking, how would you dispense the cure to the coral?
Oh, great question. How would I dispense the cure to the coral? So, very, very difficult solution. I don't know yet. I haven't gotten to that level. You're asking a great question. It's a very important question, and obviously my cure is worthless if I can't get it to, the patient, right? Same thing with the laser surgery. There's millions of people suffering with back pain that I could fix, but either they can't get here or I can't get to them. And I'm trying to fix that, obviously, at the same time as I'm trying to cure the coral. The reality is that I have to develop a strategy for doing that. Now, I will tell you this, there's two scenarios that I have to be able to dispense the cure and administer it to coral, okay? Scenario one is the coral is on the reef in nature, and it's sick, and it needs to be cured. And of course, we want to stop the transmission of disease. So, cure the individual and prevent others from getting sick. That's one of the mainstays of infectious epidemiology. Those two points. Cure the infected individuals of their infection and disease and prevent others from getting infected, okay? So how do you do that on the reef? We would have to treat each sick coral individually, and we would have to prevent it from spreading disease to other corals on the reef. Now remember, the disease leaves the coral whenever it wants to and swims away and just looks for another coral. And it doesn't really look because it doesn't have eyes, but it just swims around till it finds another coral. And I found some interesting stuff last night in my research. I'll share with you in a moment. It's quite fascinating. It's the first time I've seen it. Behavior with the philasters. So the second scenario involves corals that are located in, for lack of a better term, let's call it an aquarium. Most of us know what an aquarium is. An aquarium is a glass box that we build and we fill with salt water and we put corals in them. So there's actually millions of coral hobbyists around the world that keep corals. And I'm one of them, and that's how I actually discovered the disease, is because I keep corals at home. It's kind of like a garden. You're gardening, but you're gardening, instead of with a plant, you're gardening with animals. Of course, in reality, if you want to get technical, when you garden outside on the soil, you are working with animals and plants, right? Because every garden has earthworms. Earthworms are animals. Every garden has insects. Insects are animals. Every garden has molds and viruses that you don't want, but you have to treat. So a garden is a lot like a reef, but it's on land. The only difference is in a garden, you're trying to grow plants and fruits and vegetables. In the ocean, you're dealing with an animal. The animal is the coral. Coral is an animal. It's not a plant. And coral has a symbiotic relationship with a special kind of algae called zooxanthella. And the zooxanthella swim around. They're microscopic. They're very small, much smaller than the coral. And they live within coral and other marine life that houses zooxanthella or algae. Now, the coral provides the zooxanthella protection, all right, because there's predators that want to eat the zooxanthella. And the zooxanthella living in the coral's house under its tissue, coral provides the zooxanthella protection, and the zooxanthella in turn pay rent. And the way they pay rent for the space they take up is by using sunlight, converting sunlight energy into sugar which is a form of potential energy. Chemical potential energy is sugar. And so by producing sugar for the coral to eat and use as energy, by producing amino acids and other important molecules, these zooxanthella share responsibility of life and growth with the coral. Okay, it's a beautiful relationship. Now, these aquariums that people have, and there's over 1 million people with aquariums worldwide in their houses that house and grow coral. These aquariums are obviously a controlled environment because they're 100 gallons, 200 gallons, 1,000 gallons, 10,000 gallons. The point is they're not the ocean with infinite amount of water. So you can actually use the water column or water in the aquarium to administer a treatment to the coral in an aquarium situation. What I'm getting at is the challenges of treating sick coral infected with philaster in an aquarium are much different than the challenges of treating standby laser, than the challenges of treating coral in the open ocean. So I have very close to finalizing the treatment of coral in an aquarium with my latest invention that I have. And I next have to turn my attention to saving corals on the reef. So, yeah, there's a lot of work ahead to do with respect to coral disease and curing the reefs. But I have literally zero support. It's just me. And I've been funding this myself with my own money. And the IRS of the United States, the Internal Revenue Service, you know, is going to wonder, what am I doing with this money, investing it into this research in coral? So I have to have a chat with my IRS agent and my attorney and my accountant. But the long story short is I have zero funding from anyone. It's just me. Same thing for Deuk Spine Institute. I cured back and neck pain and developed the techniques and the team and the equipment and the medication and the protocols, including therapy, et cetera, all that was developed on my own dime. There's been no investment capital. There's no money tree growing in the back. There's no endowment. I'm not independently wealthy. I had to do it all on my own dime. So I'll be honest with you, not having a lot of money to do it has slowed the development down. But I don't understand why people like the Facebook guy, Zuckerberg, or the Amazon guy, Bezos, or Bill Gates, why they don't pay attention to people like me, frankly, that are pioneers making huge discoveries, why they don't come in and support us. They just keep giving their money to the same people that do absolutely almost nothing with it, in my opinion. Of course, caring for children and sick in a hospital is a great thing, and I would never take the money away from that. But there's a lot of wasted money that goes into philanthropy that never actually sees anything significant happen. And it's just kind of frustrating to me. Obviously, I don't have access to those funds. I can't talk to Bill Gates. I can't talk to Mark Zuckerberg. I don't have a fundraising person that is here living in Brevard County or anywhere that's helping me raise funds so that I can continue my research or improve my research or even hire a PhD or a postdoc to come help me. But we need irrigation, yeah. But I need something like that in order to get more done, because right now I'm doing it all myself. Now with the spine side, I don't do everything myself. I've got a great team of people. But on the coral side, it's just me, you know, and I have 1 or 2 people donating sick corals to me, you know, so I can do research on them. But all the other expense and management is done by me. So I need help, basically, is what I'm saying. So if the world wants a solution faster, it's going to have to get more actively involved in being part of the solution rather than just standing around and watching and waiting, which is what's happening now. You have a question. All right, we have a question from the operating room. Yes.
Does water temperature affect the infection?
Does water temperature affect the infection? So we have a question about the coral diseases. We've heard a lot in the media about global warming and the effect on coral illness, but the truth is that what we're seeing with the bleaching of the corals with water temperatures going up is extremely rare, and it is not the cause of 98% of the die-off of coral that we're seeing on the reefs around the world. So the answer is water temperature does not affect the infection. It may speed it up a little bit because the corals are more stressed. And we all know that any animal that's stressed succumbs to disease much easier, right? That's a universal truth. If your body is weakened by stress for some reason, you're gonna more likely than not, when you're normal, you're gonna more likely display symptoms of infection or disease. I don't think water temperature has anything to do with the transmission of the disease, except that if a coral dies, it releases millions and millions of this protozoan, this infection. So the more dying coral, the more protozoans in the water. You need to have the protozoans in the water swimming around to infect new corals. So I think that you can spread the disease faster if the water temperatures are higher because it stresses the corals. They succumb to disease quicker and release the protozoans. Does that make sense? So water temperature itself doesn't affect the protozoan. It doesn't care if it's 75, 65, 90. It is literally, I can talk about it, but it is really has evolved over hundreds of millions of years to become the perfect predator of coral in every way. I mean, there's so many physical and behavioral attributes of this predator, this philaster, that make it the perfect coral predator. And what I mean by behavior is its behavior, which is genetically encoded because it has no brain. So it can't learn. It can't learn like you and I can learn in our lifetime. It has to learn over millions of years through natural selection, right? So that's how it learns, quote unquote learns, is that the ones that aren't better adapted to the environment die before they reproduce. The ones that are better adapted undergo, sexual reproduction, and they have long lives where they reproduce lots of clones, identical offspring. So definitely the environment and the coral, the host, and there's been, obviously, if I look at the corals, I look at the philaster, there's been a lot of coevolution where the philaster has evolved to be the perfect predator of coral. I mean, its shape is perfect for slithering around inside the gastrovascular cavity of coral, which is really the main reason it's gone undetected all this time. It's microscopic, and most people that deal with coral don't have a microscope. All these hobbyists that are growing coral, they only look for pests that are macroscopic, that you can see with your eyes. So a microscopic pest, just like the virus from AIDS, HIV, has went undetected because people didn't have microscopes, right? They didn't have electron microscopes. They didn't have assays that they could do to find out what's killing all these people and giving them AIDS. So it took the right person with the right technology to come along and just make the discovery. So these corals have been dying for probably 100 years now, really at an accelerated rate. And the most acceleration has been over the last 50 years. And honestly, it coincides with pesticides for agricultural development of these tiny island nations where they want to become less dependent on imports, and they want to start growing their own farm products. So they brought in fertilizers and pesticides, which when you live on an island and you have a lot of rain, where do you think those pesticides are going to wash off to? They're going to wash into the reef. And I think those pesticides have been killing the natural predator of the philaster. And the philaster is immune to these pesticides. And that's another reason it's incredible, because in the hobby, everyone uses a pesticide to kill coral pests, but the philaster is completely immune to the pesticide. It's called Bayer insect something. It's literally a neurotoxic chemical that everyone uses to try to kill pests on coral in the hobby, but the philasters are 100% immune to it. I've done all the studies and shown it in my videos. They swim around in that stuff like kids swim around in a swimming pool on a summer afternoon. I mean, they love it. But I think the pesticides killed the apex predator for philaster. So anyway, I could talk for hours about this stuff. There's so much information that I've learned from studying these things and over the last year since I made the discovery. But what questions do we have, Zach, from our audience? There's the tear, by the way. You see those two white things? Those are the two halves of the tear. So we're cleaning up the tear, debriding it. The blue stuff there is a herniation right there that I'm zapping away. The green color, for those of you wondering, is just the targeting beam. The laser beam itself is not visible, right? The energy from the laser beam is invisible. It's electromagnetic radiation. It's very high frequency radiation. It's high frequency, right? Higher than visible light, but 2100 nanometers. So it's outside the visible light spectrum. You can't see it. That's why lasers are so dangerous. You know, when you play with them, you can zap your eye with a laser and not even know that you've done it because you can't see the actual laser beam. But what you're seeing, the green thing, is the targeting beam. It's actually a light that's created and transmitted along with the laser beam through this glass fiber for the sole purpose of basically letting me see where the laser is going to blast. And honestly, I already know where the laser is going to blast because it's got a 0.5 millimeter glass fiber tip, and that's where it's going to blast. So you just have to follow the blue line. My son will get a chuckle out of that because that's what he was told to do as a driver. Follow the blue line by his very first driving coach. Brake late, follow the blue line. The blue line, of course, being the racing line. For a driver, drivers know what a racing line is. It's the place you're supposed to be on the racetrack at every single instant. It is the fastest place, the fastest race line, the fastest way around the track. So there's a blue line being the casing around the glass fiber, and you just follow the blue line. You can see where the laser is going to zap. All right, what other questions do we have there, Zach? I'm sure they're building up at this point.
We've actually got through them all for now.
What's that?
We've got through them all.
We're through all the questions. Okay. Did I do a good job, Zach, of answering them, or should I expound on any topic? We've had excellent questions from the audience today, by the way. Some of them are we've already answered in the past with prior broadcasts. But for those of you who joined us late, you're watching spinal surgery for a herniated disc, the most advanced surgery in the world. This would be equivalent to a stealth bomber or a stealth drone bomber, I suppose, nowadays, for treating herniated discs. 99.9% of spine surgeons don't have this technology. They're not able to do it. They don't have the training. They don't have the experience. They don't have the equipment. As a matter of fact, probably most of them don't even know it exists. But I learned about it about 15 years ago, and I went overseas to learn from the masters of endoscopic spine surgery. That was the South Korean surgeons, neurosurgeons that were doing it in the neck and the back. I also learned from a German surgeon, Sebastian Reuten. I learned from English surgeon, Dr. King, from an American surgeon, Dr. Anthony Young. And there were other ones that I won't mention, but equally important, all of them in teaching me the basic fundamental skills for doing endoscopic spine surgery. Then I took all the techniques that I watched and saw, and I started to apply them to my patients in my practice about 14 years ago at Deuk Spine Institute. And I started to look at my results, and basically using feedback on myself, and from my patients, I was able to modify the surgery, and now we have what's called the Deuk laser disc repair, which is my own version of the surgery, which I'm entitled to have. It's been peer reviewed and published. It's actually the only endoscopic surgery that the technique has been peer reviewed and published. Everyone else that does endoscopic surgery has, just done it based on the training they get, but very few surgeons actually publish their results. And I've published the results as well as the technique. I've presented this technique at many meetings at the American Association of Neurological Surgeons. I've been to Hong Kong and presented this technique in Hong Kong, in Chicago, in Miami, Florida, Los Angeles, California. Yep. And I'm asked to give talks on this technology and technique all over the world. Of course, I don't go because I have a lot of work to do here. So I can't be running around the world teaching other people how to do it, but they're welcome to come here and learn. So we have a fellowship program at Deuk Spine Institute in laser endoscopic surgery, open surgery, and also interventional pain management with Dr. Patel. And we have fellows that come here from around the United States who are physicians that want additional training and expertise in management of pain through these these techniques. We call it interventional pain management. So I'm just finishing up L5S1. I'll be done with it in just another minute or two. We're right at the foramen entrance, right outside the disc, just about to exit the disc itself. I'm cleaning up the annular tear. It's called a debridement, or an annular debridement. That's what is happening. That's what I've been doing pretty much the whole time. That annular debridement, the only surgeon in the world that does it is me. Of course, there's other people that will copy me, but I described it first in the medical literature. It's documented in the National Library of Medicine in the United States in a published paper from 2012 in a journal called Surgical Neurology International. It's an open access journal. It's free to the public. You can go and download my papers where I publish the surgery and the technique. It's called Deuk Laser Disc Repair. You just search PubMed for it and you'll find it. So it's all FDA approved 100%. None of the surgery is experimental. We had to go up against the government of the United States, TRICARE, the military. We did about 20 of these surgeries on military personnel. The government approved all the surgeries and then got the bill for the surgeries and said, oh crap, just like they do with the VA system, they don't want to pay for medical treatment for any of our veterans or active military. So despite the patients doing fantastic with the surgery, wanting the surgery, signing up for the surgery, having the surgery even done, the government, TRICARE, tried to retroactively deny. It's actually Humana that managed TRICARE, deny paying for 20 surgeries. So we went to the mat with them and sued them and won in court. And we've been paid for the surgeries. And most importantly, the decision in court was that the surgery is medically necessary and should be paid according to the code that we use, which is an unlisted spine code. So we had two giant victories there with the judge, a federal judge, a military federal judge, as well as the Secretary of the United States for Health Services wrote a letter basically acknowledging that the surgery is medically necessary for herniated discs and that that Humana had conducted sham peer reviews to try and deny the surgery. Why am I talking about it? Because if there's other doctors out there that are encountering the same thing, which I'm sure there are, when you have a technology that works and it's new, the insurance companies don't want to pay for it because they're afraid everybody will sign up and they'll have a big bill to pay. And that's what they're there to do, by the way. but it affects their profits. So unfortunately, the insurance companies are full of greedy people who don't want to pay bills, right? And as a result, they're willing to let people suffer instead of covering these important treatments. There's the nerve right there at 3 o'clock. It's just underneath that fat. But you can see the disc herniation's gone. Let me just go in there with a grabber real quick just to make sure. But remember, folks, justice shall prevail. But only when you hold evil accountable will it prevail. If you don't fight evil, you just let it win, then it will destroy everything we have that's good. And that's what's happening, unfortunately, with the health insurance companies, is they're so powerful, they write all the laws at every state, basically protecting themselves from having to pay for your medical care. That's why the number of people going bankrupt, Skopoff, in the United States, the number of people going bankrupt keeps going higher and higher every year. Millions and millions of people claiming bankruptcy. And what's it for? Medical bills. That's the number one reason for bankruptcy in America today. People are going bankrupt over medical bills that are unpaid by their insurance company, and they can't afford to pay them. This is something new, folks, and it's new because never before have insurance companies been so brazen, so neglectful, so greedy, and they're getting away with it, right? Now, if you live in a community and you have a rapist that lives in your community, and the rapist goes around raping one woman and gets away with it, and then they rape a second one and a third, or a man, and who's going to stop them? If you don't stop that behavior, it's just going to get worse, and more people are going to get affected and hurt. And that's what's happening right now in America and around the world with healthcare. The insurance companies are multi-billion-dollar companies. They write the laws of the land to protect them and allow them to continue to rape society. By rape, what I mean is they are taking your money in the form of what are called premiums, which, we all pay our insurance premiums when we're working, but people also pay premiums in the United States for Medicare and Medicaid. Those are your FICA and FUCA taxes. If you look at your paycheck, what is it?
The other fire,
Yeah, you got to remind me.
that's what I'm saying.
Yeah, so if you look at your paycheck, you pay FICA and FUCA taxes. Those are Medicare taxes, okay? And that money you're setting aside your whole career so that you can pay for insurance called Medicare, which comes in at 65, and it's supposed to cover all your medical needs. Well, what's happened is Blue Cross Blue Shield has gone to the government and said, hey, you are giving people with bad knees artificial knee replacement surgery, and you're helping them. But you don't need to. You can save that $50,000 surgery and not pay the bill. And Medicare went, what? Are you crazy? And they go, no, we do it all the time. It's called a denial. But what's the reason for the denial? You don't need a reason. We just make stuff up. It's not necessary. 90% of the time, the doctor won't fight us and we get away with it. And now we've just saved $50,000. So we can do that for you, Medicare, government. We can do that for you so you're not the bad guy. And the government said, United States government said, oh, wow, you're going to save us a lot of money. Yes, we will, is what Blue Cross said. And the government said, well, how are we going to do this? And then Blue Cross said, we're going to create what's called a MAC, a Medicare Administrator. MAC, a Medicare Administrating Company. And of course, we don't want our good name of Blue Cross Blue Shield to be known as the denier, so we're going to create a company called Norian. And we will contract with the United States government to administer and oversee all Medicare benefits of California, Oregon, Washington State. Well, actually, there's a map on Medicare's site that shows you where Norian covers the states. So, the government said, well, what do we have to pay you for this? You don't have to pay us anything. We're going to do it at no charge to the government. Now the government's hearing this going, holy crap, this is the best deal we've ever heard. So you're going to save us at least 50% of what we're paying out on Medicare benefits, and we don't have to pay you a dime. And Blue Cross said, nope. We're gonna take 30% of every dollar we save you as our fee. And the government said, well, that sounds good to me. I don't pay anything. It's basically a contingency. If you save $1, you get 30 cents. We keep 70 cents on every dollar. I like it. And that's exactly what's happening in health insurance today, and not only in the United States, but in England and everywhere else around the world, which is why it's so hard for people to get health care, is because the insurance companies have rewritten the laws. Yeah, I need you to push my tape in. So that they can deny medical care. And they benefit by getting a commission on every dollar they save. So why am I talking about this? Because this is probably the most important topic to talk about in healthcare. And because I'm paying for this broadcast. So, since I'm paying for this production, and I'm producing it, and I'm directing it, I get to talk about what I want to talk about. And what I'm talking about are probably the most important things you need to hear. Whether or not you want to hear it or whether or not you agree with me, it doesn't matter. I have nothing to benefit by telling you the truth. I'm sure there's probably a crosshair on my back every time I leave my building and go home every day for telling the truth. But you know what? I'm not afraid to die, and I'm not afraid to pay for telling the truth. I'm just not. I've had a really good life, so if they're going to take me out, they're going to take me out. You think I'm joking about this, but there are people who have stood up to the insurance companies over the years, and they become targets, for sure. All right, let's see, 5, 4, 3, 2, so this is 2, 3. So I've got the guide wire in. Notably, it was one against State Farm, shot back in the 70s. And the person that turned on State Farm, of course, the biggest auto insurer in the world, but the person that turned was the head of their special investigations unit. This person saw such corruption in State Farm that they couldn't take it anymore. I mean, can you imagine how bad it must have been for them to like turn away from a job that probably paid them $1 million a year to actually turn State Farm in and testify against State Farm? So I'm not the first person to stand up against the insurance company's evil. There haven't been many of us, but there need to be more. And I do it not for me, because I get no benefit for doing it. I get no money, no sponsorships, nothing. I do it because I'm trying to help you, the 99.9% of people out there that are victims to what the insurance companies are doing. So, but there's only so much I can do, folks. I can make you aware of the problem. I can educate you on the problem. But fixing the problem is not in my purview. That's you. You all have to fix it. And I can tell you the only way you're going to fix it is by rewriting the laws of your state to prevent insurance companies from denying medical care that your doctor orders. That is the only way it's going to be fixed. There's something else that should happen as well, and that is patients should start writing checks for their medical care. Submit those bills to their insurance company and let the insurance company pay the patient directly. And the reason for that is the insurance company will be accountable to each and every beneficiary directly. The beneficiary will go back to their employer and report whether or not the insurance company is behaving. The employer will have then the ability to assess whether they want to maintain their relationship with that insurance company. Right now, the insurance companies are so smart, they've subtracted the patient out of the equation and they subtracted the employer out of the equation. So it's just the doctor fighting to get the patient the care they need. And most of the time that's just not enough. Let me have the impactor again. So we need to have every patient advocating for their health care. And they need to be going to the most powerful people in the world, which happen to be the employers. If you work for a company, you have an HR department. That HR department selects the insurance company for health benefits for the next year or next 2 years. You need to talk to your HR director. You need to talk to the CEO of your company. You need to share your opinion, your experience with the insurance company with them. But you need to find out the facts first. And the facts are, what is your insurance actually paying for? I'll give you an example. I've told this story before, but we had at Deuk Spine Institute Blue Cross Blue Shield. And we paid $300,000 to them over the course of 1 year for our employees for their premiums. Some of our employees did get sick and go to the hospital or doctors, and there were claims made. So when I called Blue Cross Blue Shield as the CEO of the company and said, how much did you pay out in that year in claims? They said, we cannot tell you that. I said, yes, I want to know. And they said, we are not obligated to tell you that by law. We're protected. We don't have to tell you how much we paid in claims. Well, I found out they paid out 10% of the claims, 10% of the claim amount. So we paid $300,000 in premiums. The claim amount was $270,000, so less than $300,000, and they paid 10% of $270,000. They paid $30,000 out of their coffers, but they collected $300,000. You do the math. That's a 90%, basically almost 90% profit. Of course, they have administrative costs, but everything is computerized now, so they don't have a lot of people to pay. 90% of every premium dollar basically went into Blue Cross Blue Shield's pockets. And that was a good plan for a doctor and his staff. Like, they come and say, we got a great plan for you, better than what everybody else is getting. If they're keeping 90% of every dollar we're paying here, what are they keeping for the general public? Right? What are they keeping for Harris or anybody else that uses Blue Cross? Folks, I'm not picking on Blue Cross by any means. The same thing happens with United, Cigna, Aetna, Humana. All the big insurance companies are ripping you off exactly the same way. So if you want to change healthcare and make it better to where you can go to the doctor and the doctor says you need this test, this MRI, or this medication, and you don't want to get a denial, then you need to take back control of healthcare, which you, by the way, you all had when I was a kid growing up in California. Okay, you could just go into the doctor, you pay $5 copay, and the doctor ordered something and you got it. The insurance company just paid the benefit. They didn't interfere with what the doctor ordered. That's all changed now. They basically deny almost every claim, every request for authorization, because there's nobody to police them and stop them. So just to give you an idea of what's happened over the years. Yeah, I'm going to use side firing too.
Yeah.
Yep. All right, we're on our last disc. This is going to be L23, right side. And we've already done L45, L5S1. You can see a tear in the disc already. Grabber. Any questions, Zach?
What?
Sure.
You asked, can this surgery help with back pain that's caused by bone spurs?
So can this surgery help with back pain that's caused by bone spurs? 100% yes. It can. This is the perfect surgery for back pain caused by disc or bone spurs related to the herniated disc. All right. Now I'm going to get the side firing laser in here in just a minute, so get it ready. I want to just do a little bit with the front firing. There's a big piece of herniation right there. Let's see if I can free it up and grab it out. Standby laser. That's a nice big one right there. Hopefully it'll come out as one big chunk. You can see how smooth the surface is of that herniation. That's because of the inflammation that's been working on it for probably years. Oh, it's too big. Here, there's part of it. Yeah, but there's... Let's go. Don't take forever. All right, let's see what we got here. More pieces. So I finally watched the Godzilla movie we've been talking about. And I was just telling everyone how disappointed I am. It seems like quite a few movies nowadays are made overseas. Of course, Godzilla's always been overseas, right? But, yeah. The monster itself looked good. The special effects were phenomenal. The storyline just sucks. And the character development sucks. And, just, unfortunately, it could have been a lot better. Look at the size of this herniation. That's a good one. Oh, baby, you got to get this, Zach. Look at that thing. Can you see it?
We can see it, yeah.
All right, nice and juicy, the size of a marble. Now, why was it deep inside the disc? Because I shoved it in there, right? Remember when I put that dilator in? It basically reduces the herniation. That's one of the advantages of this technique. It's actually not unique to Deuk laser disc repair. Let me have the grabber one more time. It's actually anybody that does this procedure using this equipment gets that benefit of the procedure of pushing the herniation from the foramen or epidural space into the disc. Yep, there's another piece right there. So that's not unique to Deuk laser disc repair compared to the same, somebody using the same equipment from Richard Wolf. Of course, Richard Wolf is a German company. These equipment is all made in Germany. And of course, Germans do a good job of manufacturing things. We all know that. But they do a horrible job of promoting and educating surgeons. And I've been trying to talk to them and work with them, but they're a bunch of idiots. Yep. Bunch of idiots, folks. Why? Because they have incredibly good equipment. All they need to do is train the surgeons. But they need surgeons to train them. Good surgeons. And they, most importantly, need to work on the reimbursement, because the reimbursement of this procedure is very poor by the insurance companies. So that takes a lot of effort, a lot of lobbying and money and time, but they haven't even started. And this has been out for 20 years. So it's just horrible business strategy. Every single, company that makes a medical device has to get it FDA approved first, which they've already done. And once you get it FDA approved, they need to work on getting it, promoting it, getting it out there so that doctors learn it. And Richard Wolf has done a horrible job with that, unfortunately. They could have done a lot better job. I've tried to help them with it, standby laser, but they just don't listen. You guys should be promoting this surgery too. You guys make the laser for this. Honestly, if you guys wanted to hold some workshops, I'll train spine surgeons. And we can train them on your laser. Then they go out to their hospitals and they'll buy your laser for $100 grand. Yeah, let's do the side fire. Let's do the side fire. We're going to use a side firing laser fiber. We want to make sure this is going to work. Don't lose control of that one. This is a good time for questions. Any questions from our audience?
We were asking, how can we as consumers assist in the fight against the insurance companies?
So somebody's saying, how can we as consumers assist in the fight against insurance companies? Think about it this way. I gave the analogy of there being a rapist living in your community. You have 1,000 people who are good, honest people, and you have one really bad person who is abusing people, hurting people, breaking all the rules, doesn't follow the rules. Well, the first thing you have to do is you have to make rules and laws that say that rape is wrong. It's bad. It's harmful. It should not be tolerated. It should be illegal. So that's step one, okay? You need to go and change the law in your state. And the only way that's going to happen is by forcing your senators and congressmen to write laws that take away, that basically make illegal what that person is doing. In this case, you're talking about an insurance company. So what are they doing? They're denying. It's that simple. So if,
Longer, we can do it longer if you want. But just,
yeah, I think it's fine where it is. You know, seeing the targeting beam is kind of hard. I just have to rotate the scope. Yeah. So, oh, that's cool. That's an 80 degree. Sorry, folks. I'm just talking my team right now. It is definitely takes some getting used to, but it seems to be quite effective. So, number one, you have to make the activity illegal. And the insurance companies, folks, have been working for the last 30 years with senators and congressmen behind your back. You know, literally behind your back to change the laws in every state. Now, the good news is they haven't made as much progress as you can in much shorter period of time, because the laws of every state are designed for one purpose. They're designed to protect the public, okay? To help the public. Why am I having trouble? Okay? So the laws are supposed to help the public, not help corporations. So as long as the public understands what needs to be written, then the public can advocate for laws that are beneficial to the public, which is you, which is what I'm trying to help, is you people. Everyone out there that needs help in medical care, not just spine care, every kind of medical care. I mean, it's horrendous the amount of denials that are occurring. So you have to make denial for medical necessity illegal for an insurance company to deny what the doctor's ordered. Now, let's just say they disagree, right? Then it should go to a committee of doctors that are not controlled by the insurance company, a committee of doctors and the public. I would just suggest 50-50, let's say. Maybe even some lawyers, doctors, nurses, therapists, machine workers, auto workers. I mean, it should be people that are on that committee that really want to do what's right and not they're working for the insurance company, okay? So you need a committee that will decide if the insurance company's choice of saying no to what the doctor ordered was appropriate, okay? And only then will we be able to get just health care in our state or our country. So number one, take away the insurance company's ability to deny doctor-ordered health care. After all, doctors go to medical school, doctors train, doctors go into medicine hopefully to take care of patients and do what's right for the patient. The insurance companies are fighting the doctors every single day and saying no to what we order, and every day it's getting worse. So the number of denials has gotten into the millions every day, whereas it used to be maybe 1,000 a day across our country. It's now millions a day. So number one, write a rule or law that prevents the insurance company from denying what the doctor orders for treatment, okay? That whether it's admission to the hospital, go to the ER, get this MRI, take this medication I like, all that has to be stopped. The insurance company should not be able to deny what the doctor orders. Now, if they really feel strong about it, then a committee, not from the insurance company, but a committee of publicly elected people or appointed people, but not by the insurance company, by, you know, hospitals perhaps, by doctors, by therapists, nurses, a committee that should sit down and decide whether that care is medically necessary under those circumstances. Very easy to do. Very, very easy to do. It's actually done already, usually by the Board of Medicine. All right, so that's number one. If you can fix that in your state, if you can advocate to your senators to take away the insurance company's ability to deny. And what I mean by deny, I mean either refuse to approve or refuse to pay. Denial is a refusal to approve or pay for medical care. So if you take the insurance company's ability to deny or refuse to approve your medicine, your MRI, CAT scan, whatever, blood test, If you take that away, or you take away their ability to refuse to pay, you have the greatest victory. It'll change everything. People will not suffer anymore. People will get the care they need. Denying medical care for pre-existing conditions, where did that ever come out from? That's a creation of the insurance company. It's so unfair. That means if you ever get a medical condition in your life, the insurance companies can basically say, we're going to cover any new problems, but we're not going to cover that old problem. Who's going to cover it? Right? The purpose of the insurance company is to spread risk so that you're not paying for it, but that it's spread out over a population. And that's what they should be doing. But there's nobody that stand up to them, to their denials. I'm standing up to them, but I'm fighting them on every individual case. But I'm helping 100 people. But we need millions of people to be helped. So this has to be done across the nation, at every state. And it's the state government that makes those determinations about whether an insurance company can deny or not. So you need to work at the level of the state. That's the best answer I can give you right now. I can go into more detail, but until we start, fighting this battle against the insurance company, they're literally poisoning and taking over your world. Because without your health, you can't work. You can't have hobbies. You can't live life. There's no point in living life. You understand? People just sit at home and they're in pain all the time, or they're addicted to marijuana or whatever, drugs, opioids. It just ruins their life. All right, this is interesting. I don't know if it's what I want to use on every case, but you can see the end plate over there, the pink thing on the left. But it's let me just, I'll play with it a little bit more. It's a single use, right? Yeah, yeah, but it also damages the tube a lot more too. You see that? All those welded spots. Plus, I want it to get closer to that right side at 3 o'clock. It's just too far away. You know what I mean? I want it to get closer. I'm trying, and I like the little red doohickey, but it's just not getting over there far enough. So honestly, I think the straight firing fiber is going to be better most of the time. Yeah. What's the width of this?
The fiber itself is 550, but it's
So it's the same as a blue.
it's the same as the blue. What's coming out of it, but where the grip is, the thicker portion is like a 7.
You're talking about the brown plastic. So you're saying the glass part is 550. Got it. But the sheath over it is thicker with the side firing.
I'm noticing a little bit more spark insulation, maybe quicker, but I'm not sure if it's good for you. Right? So
Yeah, I don't know. I'm not saying I won't use it again. I'm just saying that, I'm not sure I think there's definitely some cases I would use it. But still, look at it. I just can't get closer to that surface. Let's go back to the straight. And I may come back to that again, but it's really damaged the inside of my tube. Look at that. It's just... So people wonder, can lasers get rid of bone spurs? Look at what it did to the metal. You guys see that at the periphery of the tube at the end there? It's melted steel from the laser. And that was at 30 watts, right?
correct.
Yeah, so this machine can do 100 watts. We used 1/3 of its power. So yeah, we could juice it up to 80, 90 watts. And really, there's no bone spur that can stand up to a laser. Take your time. Thank you. All right, great question. Are there any other follow-up questions to that point? You do have what? I'll take them. Any question people want to ask me, I'll try my best to answer.
What is the actual size of the disc material that you're using?
So what's the actual size of the disc material? That piece that I took out a few minutes ago and showed you all, that's like a big herniation piece. It's probably about 10 millimeters or 1 centimeter wide. and probably about 2 to 3 centimeters long. So I would say it's a grape, the size of a grape, like a small grape, maybe a red grape, a small red grape, not a tiny red grape, but you know, a medium-sized red grape, let's just say. Now I've taken out big white grape-sized pieces before, but those are rare. Most of the pieces come out as little flecks. Like if you look at the laser right here, 1 minute you see some tissue and then the next second it's gone. Those are basically being blasted off by the laser energy, and they are getting wet feet. I don't know why. And they are going into the water and they're floating up. Let me have a grabber. Laser standby. Can you time me again? Never mind. All right. That's definitely a herniation right there. You can see, yeah. Oh yeah. There we go, baby. That's a good one. That's a good one. So there's another chunky one. Looks good. Take that. Give me that. Tie it off. So what are the questions, Zach? Did I answer that last one good enough or what? It's a great song. Can we turn this up? Good old Scorpions.
Yes, sir. We have a photo of you asking, what is different about the new laser that you're using?
What's different about the new laser? Okay, so very perceptive. If you're asking about the fiber I used, the fiber I'm using right now that you can see is a straight firing. Basically, the laser beam comes straight out and shoots straight along the axis of the optical fiber, the blue fiber, let's say. The last one I used, the beige one, it actually shoots to the side. So it's called the side firing laser, whereas right now the blue one is a straight firing. So the blue fiber that you're seeing right now shoots straight. The last one shoots sideways. And we were testing it out to see if we could do a better job with getting rid of the disc herniation, but in my opinion, it definitely did it a little bit different, but I don't think it was dramatic enough to use it. I couldn't get really to where I wanted to. I think that basically this is going to remain as my mainstay. For 15 years I've been using the straight firing laser. I was aware of the side firing laser, I just chose not to use it because I didn't really like it as much. But I figured I'd try it out and see if I could do something different with it that was better. My assessment is that it's good, it's just not going to be my best tool. What is that? Oh. All right, we got about 2 more minutes and we should be done with this disc. And you can start seeing at 12 o'clock the epidural space. You can see the end plate on the right and the end plate on the left. That's going to be your L2 and L3. We're going to see the nerve root in just a second. It'll be the patient's right L2 nerve root in the foramen, exiting the foramen underneath the pedicle of L2. Just about done. 30 seconds. And I'm telling my anesthesiologist I have 30 seconds so he can start to wake the patient up. Dr. Patel wants to do the injection right now? Yeah, I'm done. Get him in here. I'm done. But he wants to do it while she's asleep, right? Yeah. Let's get him in here. Maybe you can do her bursa real quick. What do you think?
Do the what?
Maybe you can do her bursa? That's pretty easy, right? Watch this, Flora.
Because they want to do the ultrasound guided.
Oh, for the bursa too? Oh, you guys use the ultrasound for the bursa? I didn't know that. That's cool.
We do them with
All right. So we're done. The herniation's gone. You can see the nerve here. Standby laser, laser off. You can see the nerve is going to be right there. That's the nerve, folks. It's got a little bit of fat and connective tissue around it, but that's going to be your nerve, and the herniation was right there. We're done. So thank you. Yeah, no, I really like the laser. So the new one, the 100 watt that we're looking at getting, would have the same power curve and everything, right?
Exact same power.
So we would have a really nice power experience like that,
It would be perfect.
and just one pedal.
Exactly. In case you're experiencing hitting both pedals at the same time.
Yeah, I have a big foot. I have a size 13 foot. Yeah, I don't want it to keep hitting those two pedals. All right, folks, I'm going to come to the conference room and answer any other questions you have. I'll be there in 5 minutes, so stick around, type your questions, and we'll get to answering them. Okay? Good job, everyone. Nice work. Where is the ultrasound machine?
It's right up here.
All right.
that okay? All right, we can hear you.
All right. Can everyone hear me? I assume the answer is yes. So sorry about that. We had some technical difficulties with the microphone. I left Zach in here with the microphone, and when I came back, it wasn't working. It makes me wonder what Zach was doing with the microphone. Just kidding. So, Dr. Deuk Majan here, and we have a question. Someone has asked, is the tube single use or autoclavable? If latter, is the current one now redundant due to the damage? So the answer is that metal tube costs about $1,200 to $1,500, and they are definitely autoclavable and reusable. They are not single use or disposable. So we don't want to damage that tube. The damage that you saw was about 0.05 millimeters worth of damage. It's just magnified. And so those little blast marks are very minuscule. They're tiny. They're not a problem basically. So if any kind of metal that you have in your life that you use gets those little kind of bends and frays, perfectly normal. But the tube's structural integrity is still good. Hold on 1 second.
Bring her back. She's died.
Okay, I'm back again. Just had to discuss the patient's care with Dr. Patel. All right, so to answer the question, the tube is going to be used again, and the damage you saw, highly magnified, is very insignificant. But obviously, the cumulative effect of laser blasts on the tube, eventually you won't be able to use it anymore. Next question. What are the potential complications for this surgery compared to a back fusion? So one of our viewers has asked, Dr. Deuk, will you explain your Deuk laser disc repair surgery we just watched and compare it to a fusion surgery? Now, this is a great question. I love this question because we're comparing two different surgeries for basically the same problem, which is back and leg pain from a herniated disc with a pinched nerve. So I'm going to start by saying that it's not an easy comparison for one reason. The way I do fusion is called the Deuk spinal fusion. It's very different than the way other doctors do their fusion. If you were to compare my fusion with other doctors' fusions, the average fusion, you're going to see major differences. So let's start by comparing a Deuk spine fusion versus any other fusion out there. So first of all, with the Deuk spine fusion, the operative time is about 1/3. In other words, the time for me to do the surgery is 1/3 of what it takes a normal surgeon to do a fusion. And instead of the patient being under anesthesia for 3 or 4 hours, my patient is 1 hour per level. So much less anesthesia, much less complications as a result of long anesthetic with the Deuk spine fusion. Another thing that I do really well with my fusions is I get rid of leg pain and leg symptoms. And the reason for that is I do a very wide decompression with the Deuk spine fusion compared to other surgeons that don't do a decompression very well. And the patient wakes up and they have the same pain they had going into surgery, or they have new pain down the other leg or in a different place because the surgeon did not decompress the foramen or lateral recess properly to unpinch the nerves that are being pinched. And The next thing is the Deuk spine fusion is done with a table called the Jackson spinal table. All my lumbar fusions are done with the Jackson spinal table. The Jackson spinal table is very special. It's a $100,000 carbon fiber table. A regular operating room table is about $10,000. So there's a reason why the Jackson spinal table is $100,000, and it's not just because they want to be paid more. It's because their table is truly better than any other operating table for spine surgery, particularly for fusion. And the reason is simple. Number one, the way your patient lays on the Jackson spinal table is very specific and special for fusion, for the lower back. It actually puts pressure points on the patient's chest and on their hips, and that way it creates a curve in the lumbar spine, the kind of curve that we want the patient to have with a fusion. The problem I see so commonly with other fusions is that surgeons don't correct the curve in the spine and put the right proper curve in. If you don't correct the patient's curve during surgery, that patient's going to end up having horrible back pain and more leg pain and adjacent segment disease, which is going to cause the need for more surgery if you don't correct the curve. And you have to put the lordosis back in the lumbar spine. I would say 95% of spine surgeries that I see done elsewhere, the surgeon doesn't correct the curve. They don't know how to correct the curve. They don't have the tools to correct the curve. They don't have the technique to correct the curve. They don't have the implants. They don't have the experience. They don't have the knowledge. They don't do it. And it's easier to do a fusion without correcting the curve. It's much harder to correct the curve of the spine. But if you correct the curve, the patient's outcomes are orders of magnitude better. So when you say compare your laser surgery to a back fusion, the laser surgery doesn't affect the curve in any way. It actually just repairs the disc. So the natural curve is still there. Now, when you go to a fusion and the surgeon uses a regular table, OR table, to do their fusion, which many do, you're not putting a curve in the spine, you're actually fusing the spine straight. And you don't want to fuse the spine straight on the side view, you want to fuse the spine straight on the front view. So you want to put a curve in the spine on the side view. We call that sagittal balance. I mean, the answer gets very complex. I could talk for hours, so I don't want to lose the audience, but I'm trying to keep it as simple as possible for people to understand. But the main thing here is the curvature of the spine needs to be restored back to a normal curve during fusion. Otherwise, you're going to be fusing the patient in an improper curve, and that's going to cause the other joints to wear down. It's going to cause the muscles to have problems and pain, and it happens all the time. But not with the Deuk spine fusion here. Another thing that I do different in my fusions is I do what's called Smith-Peterson osteotomies, which is where I'll go in and I'll cut out the abnormal facet joints at the segment that I'm fusing. That way I can actually reduce the curve and add in lordosis to that segment, which you want to do, and it allows me to properly decompress the neuroforamen and get the pressure off the nerve roots. So the Smith-Peterson osteotomy that I do during my lumbar spinal fusions is massively better than not doing a Smith-Peterson osteotomy. Probably 95% of spine surgeons don't do a Smith-Peterson osteotomy during their lumbar fusion, which is why the patients don't do very well. Okay, and so when you talk about a spinal fusion, folks, you have to understand it's not apples to apples. Every surgeon does their fusion differently. And for the ones that adhere to the basic principles of proper spinal fusion, their results are going to be comparable. Everyone else is going to be less with the results. And the patients are going to suffer because the surgeons don't do the surgery properly. So what are the proper steps? I've gone over these before, and I'll repeat them again. If you're going to do a spinal fusion, you have 3 goals as a surgeon. Number 1, decompress, which means take the pressure off of the nerve roots and spinal cord if you're dealing with the cervical spine. So unpinch the neural elements, unpinch the nerves and spinal cord. That's very important. I can tell you that most orthopedic spine surgeons don't do that. Many neurosurgeons don't do that. So it's just shitty surgical technique that results in the nerve still being pinched. But in a Deuk spinal fusion, I do it 100% of the time in every patient. Number 2, restore alignment of the spine. That means to put the natural alignment back. 95% of spine surgeons don't do this during a fusion. But Deuk spine fusions, we do. To do it, you have to do a Smith-Peterson osteotomy, you have to use a Jackson spinal table, you have to put the proper curvature into the hardware, the rods, and you have to align the screws and rods properly. So there's a lot of little details that go into getting the curve right that 95% of spine surgeons don't do. So patients are going to come out of fusions elsewhere with improper alignment, which is going to cause adjacent segment disease, spinal stenosis, radiculopathy, increasing back pain afterwards. The final stage that every good spine surgeon that does proper spine surgery fusions is going to achieve is called stability. So you have three things. Number one, decompression. Number two, realignment. Number three, stability. Those are the three most important foundations of proper spine surgery fusions. So stabilization or stability involves basically putting in instrumentation, interbody cages, and causing the bones to fuse. So if the surgeon doesn't get the instrumentation right, or the interbody cage right, or the interbody arthrodesis right, or the lateral arthrodesis right, then the fusion won't, or stabilization won't occur, which is the fusion basically. So I know I make surgery look easy, but every single second that I'm doing something is pre-planned, premeditated, and it has to be done just right to the nth degree. And if it's not, patients have different outcomes. So I want the best outcome, and I actually get the best outcome in my patients that have fusions better than any other spine surgeon in the world. I know that because I read all the papers that are published. I go to all the meetings. I watch other spine surgeons and their results. I know how good their outcomes are. I know how many complications, what percentage of relief of back pain. And what I can tell you is that there's probably the top 5% of spine surgeons in the world get very similar results. And Deuk Spine Institute's one of them. But you have to adhere to those basic principles of spine surgery, which is decompression, realignment, stabilization. If you do that on every single patient, you're going to have reproducible results in terms of outcomes. One of the other things that makes a Deuk spine fusion better than all other spine fusions is our minimal complication rate. Less than 1% of our patients having a spinal fusion will have some type of complication. It's always minor. We don't have anybody dying or paralyzed. I've never had those complications in 20 years. That comes from a lack of attention to detail. Okay? Is a patient dying from a spinal fusion? Does it happen? Yes. Not in my practice. Does it happen in other doctors? Yes. In my opinion, why? Okay, I'm going to tell you right now, there's two types of patients, what are called elective and those that are called emergency. If you're having an emergency spinal fusion, then something really bad happened, like a car accident or falling off of a roof or something, right? So you've got, the patient has all these other issues like pulmonary contusion, cardiac problems, blah, blah, blah. In those circumstances, the complication rate is going to be higher. Higher because you're in a non-controlled situation where the patient's been optimized medically for surgery. You're doing an emergency surgery. They could be on blood thinners, they could have heart disease. All those things play into the outcome of the surgery. I have the advantage in my practice of not operating on those types of patients. I don't operate on traumas in the hospital. Okay, I'm too old for that. Basically what I take care of are people who come in to the office and see me, and we call those elective cases. It doesn't mean they don't need the surgery, it just means they're called elective versus emergency. So my patients are always preoperatively prepped. They have their heart worked up, lungs worked up, blood work worked up. Basically, they're optimized for surgery. Because of that, I have not had any complications from my surgeries. No cardiac or pulmonary complications. My patients do very, very well. My results are exceptional with a complication rate of less than 1%. So I'm not trying to say that doctors that operate on patients in trauma situations having a complication is expected. Probably I would have them as well. But doctors that operate on patients in an elective situation where the patient comes into the office to be seen and then have spine surgery scheduled, patients should not be dying. Patients should not be paralyzed. Patients should not come out worse from surgery than they went in. If they do, there's something grossly wrong. And this is where the education comes into the public. The public should have expectations, okay? Unfortunately, a lot of people get their expectations from the internet. A lot of people get their expectations from their surgeon, and sometimes the surgeons aren't honest with them. But I believe in people should be educated so they can set and manage their expectations for spine care properly. And that's why I spend a lot of my time educating the public, including right now. So this has been a long-winded answer to a very good question, which is compare spinal fusion to Deuk laser disc repair. And it was not an easy answer because you first have to compare my spinal fusion, Deuk spinal fusion, to other spinal fusions. And Deuk spinal fusions has a 95% elimination of back pain that the patient has before surgery, and 95% elimination of leg pain or weakness, numbness, and tingling that the patient had before surgery. Also, the Deuk laser disc repair has 95% elimination of back pain and leg pain, or neck pain and arm pain. Okay, we do surgeries on the neck as well. So whether you're talking about the neck pain or back pain, arm pain or leg pain, the Deuk laser disc repair and the Deuk spinal fusion have exactly equal results. Okay? What's the difference? The difference is this fusion, you're getting screws and rods and metal plates put in. All right? The fusion is a much more invasive and more painful recovery, longer recovery. The laser surgery is an hour of recovery and you go home and you're back to work the next day. Okay? So with fusion, my fusion, Deuk spine fusion, patients usually go back to work in 4 weeks. That's the average. But with laser, they go back to work in a day. All right? So obviously, the benefit of laser surgery, Deuk laser disc repair over spinal fusion with Deuk spinal fusion is a faster recovery, a less painful recovery, and a lower chance of complications with the laser surgery. But if you compare Deuk laser disc repair versus the average spinal fusion, not done by me, but done by the average spine surgeon, the benefits are massively better because patients with average spine surgeons frequently have major complications from the spine surgeon, just, I won't say being an idiot, but doing things improperly or not having the right equipment, medication, or team, or training, so that they can provide the patient with an excellent outcome. Folks, I'm not going to beat around the bush and lie to you. The truth is that the doctor you go to, the facility you go to matters. And big names like Mayo Clinic, big names like Cleveland Clinic, they don't do a better job than companies like Deuk Spine Institute, for example, where we have all the best equipment. That we have better equipment than the Mayo has. We have better equipment than Cleveland Clinic has. Now, they may have a robotic device, which we don't have, and the reason is simple. We don't want one. Robots in spine surgery, in my opinion, are superfluous, unnecessary, and they do not benefit the patient in one bit, and all they do is add time and, in my opinion, risk to the spine surgery. So I understand robots are popular, but they're, in my opinion, absolutely unnecessary, and I would never use one. Even if you gave me a robot tomorrow, I would probably sell it and use the money to start taking care of people who have no money for spine surgery. I wouldn't keep it. I wouldn't use it. In my opinion, it's a piece of junk. So why is there such a hype about robots in spine? I'll tell you why. It's simple. Because the people that steal your money through stock market investments, you know, these investment bankers, for example, the people that take your money, they're going to say, oh, look, it's hot new technology. It's spine surgery. We got robots. Let's invest your money in this company making robots for spine surgery. And you might say, wow, I read that in the news. Robots are amazing. I can tell you right now, as a very experienced, very accomplished spine surgeon, you don't need a robot. It's a piece of garbage. The only reason these companies are buying them and building them is so they can take your investment money and have you invest in their company. That's it. And I wouldn't put a single dollar into those companies, knowing everything I know. Because spine is truly moving towards the Deuk laser disc repair procedure. That's what spine is going to. It's going away from big, expensive equipment and implants. So if you're going to invest your money in healthcare, and you want to make a huge profit, buy shares in an insurance company like Blue Cross or Cigna or United. Okay, but because they make a lot of profit, and they shouldn't be. So if people do what they're supposed to do and fix the healthcare system, then investing in an insurance company would be a bad idea. Let's start investing in people. Let's start investing in society. Let's start investing in health. And let's start investing in a pain-free lifestyle, which is exactly what I want for everyone. But there's obviously a lot of people trying to get in the way. All right, next question.
How soon after this surgery would I be able to go back to a normal life?
All right, one of our viewers says, after this surgery, how soon would I be able to go back to a normal life? It's a very good question, open-ended, unfortunately. If your normal life is playing football, tackle football, you're going to have to put the football part on hold. If normal life is just like for normal people, which is, you know, hobbies that are low impact, low heaviness, you know, you can do that within a day. If you're talking about driving a car, next day, go to work, next day, go out and have dinner with your friends, next day, hang out with your family, next day. I mean, literally with Deuk laser disc repair, what's one of the beauties of the procedure, you go back to a normal life the next day, the very next day. Now, you do have restrictions. You can't lift over 25 pounds for 6 weeks. I don't want you doing that because you might re-injure the disc I just fixed. And you can't play tackle football or contact sports, usually for about 3 months. So there's minor restrictions, but otherwise you go back to a normal life. Now, if your normal day, your regular normal day involves, you know, I'm just saying skydiving, you know, landing from skydiving is a big impact on your lower back. I wouldn't do it. So you're going to have to take some time off skydiving. You know, if you gave me a specific sport or hobby or occupation, I could tell you exactly when you can go back to doing those things. But it all has to do with flexion at the waist and loading of your lower back in terms of weight. So, but basically the next day, you go back to a normal life the next day. Just for the record, we've had people come in and get this Deuk laser disc repair surgery done in the morning and literally go to work that night. We had a coach of a basketball team who was in the playoffs, and he had the laser surgery done in the morning and coached the championship game at night. So I've seen people do all kinds of stuff the same day. It's you know, not recommended that you do too much the same day because you just had anesthesia, but the type of anesthesia we use for the lumbar ones is the same kind that you use for colonoscopy. And I've had it before, and basically within an hour or two of my procedure, I'm ready to go back to work, and I do go back to work. I just have too much work to do not to take a day off. So you can get back to a normal life basically the next day.
What do you do with the lordotic curve in the lumbar with a fusion when there is a loss of kyphotic curve in the thoracic?
So the good question. Somebody is saying, what do you do if I've lost my kyphotic curve in the thoracic spine, which is right above the lumbar? What do you do in the lumbar spine? I think with a fusion, right?
Yeah.
Or if you've already had a fusion.
Lordotic curve in the lumbar with a fusion.
All right, so basically my goal with fusion in the lumbar spine, what I think is the proper way to do the surgery, is to create as much lordosis as you can in the lumbar spine by putting in a huge inner body cage, as tall as you can make it without fracturing through the end plates. So you want to distract the anterior column and spread those vertebral bodies apart as wide as you can by putting in a tall inner body cage. If you do that and you remove the posterior elements, which is your facet joint at that segment, if you remove those facet joints through Smith-Peterson osteotomies and you do an inner body cage that's huge and tall, then you're going to basically, like a teeter-totter, you're going to basically create at that segment that you're fusing and treating a very good lordotic curvature. and probably add in, 3 degrees of lordosis. Every level you do the Deuk spinal fusion at, you're going to add 3 to 4 degrees, maybe 5 degrees sometimes, of lordosis. So if you add those degrees of lordosis up over 2 or 3 segments, you're looking at 10 to 15 degrees of lordosis being added to your spine, which could actually, be beneficial to your overall posture. Now, if your spine has lost its kyphosis in the thoracic spine and you overcompensate on lordosis in the lumbar spine, you're going to shift the plumb line really posterior to the sacrum, which could, honestly, I don't think it's going to do anything at all negative to a person. I've never seen any negative consequence of, quote unquote, overcorrection of lumbar lordosis, period. The problem most people have is really when they've lost their lordosis, when they basically don't have enough lordosis, when they're quote unquote kyphotic and the plumb line is anterior in the sacrum. If that happens, people have back pain, muscle spasms, they get leg pain, all kinds of physical complaints, particularly in the butt cheeks and the posterior glutes and the lower back from trying to compensate and really pull their visual field backwards so that they can have their eyes level to the horizon. So I won't go into more detail than that because it gets way beyond the level of what this broadcast is supposed to be for the general public. That was our last question. Well, thank you everybody for watching. It's been a really good morning so far. We do have 2 more laser surgeries coming up, so save your questions and we'll see you in about 30 minutes.